हेलो। हेलो। हाँ। हाँ हाँ, गुड मॉर्निंग सर। हाँ ठीक है सर, बताइए सर। हम्म। हाँ हाँ हाँ। हम्म। हाँ हाँ, मुझे मिले थे कुछ महीने पहले वो। अच्छा। हम्म। हम्म। आज आ जाए तो आज देख लेंगे सर, इफ यू कैन कम टुडे। इमरजेंसी में आ जाए, हमारा वर्कशॉप चल रहा है तो वी आर ऑल इन ऑफिस सेंटर। कभी भी आ जाए सर, हम 2 बजे तक हमारा वर्कशॉप चल रहा है। नीचे इमरजेंसी में आ जाए, मुझे बता देंगे बस। कल मेरा ओटी है सर, आई एम बिजी टिल 5 o'clock। हाँ हाँ। यस यस। तुमने एसी चला रहे सुबह 6 बजे से? कितने बजे शुरू किया? हाँ?
A very good morning to all of you. We welcome one and all to the Cornea Workshop, which is our hybrid online and physical workshop being held at RP Center Ames. So we have our chairpersons, Professor Jeevan S. Tityal, Professor Radhika Tandon, Professor Namrata Sharma, and the faculty of Cornea and Ocular Surface Units, Professor Tushar Agarwal, Professor M. Vanathi, Professor Rajesh Sinha, Dr. Nupur Gupta, Dr. Nishat Hussain Ahmed, Dr. Praful Maharana, Dr. Lomi, Dr. Manpreet, and Dr. Sridevi. I hand over the mic to Professor Jeevan S. Tityal, Chief RP Center, to introduce the workshop, and then we'll begin with the session.
Thank you, Manpreet, and good morning to all of you. Indeed, it's a Sunday. I can understand so many webinars or workshops are being held in a entire country today. But looking into our RP Center workshops, they've been there for such a long time. People wait for these workshops. Today, we like to wish everybody who are present physically in RP Center lecture theaters 6 and 7, as well as people who are going to join us today live through RPC YouTube and Facebook Live. We like to welcome all of them and wish them that they'll understand the corneal pathologies, surgeries, and the basics of doing a proper diagnosis and management of common corneal disorders. We made an entire workshop in 4 categories. So first is the ectasia. You all know ectasia is the one of the leading corneal problems where patients come for a treatment management, and sometimes very difficult to diagnose them in an early stage where it can be halted to decrease the problems faced by these young people. The second category is near life surgery, where we have a various surgeries which are commonly performed by corneal surgeons as well as the general ophthalmologists also. And third category is very important, that is corneal infections, which we understand is one of the significant comorbidities of eye, which people get to see right from the community level to our higher centers also. And every time people do struggle to make a proper diagnosis, proper treatment for these patients to save the cornea and maintain the vision of these patients. And third category is also very important for everybody, that is corneal emergencies. So we have these 4 gamuts of clinical lectures, demonstrations. Apart from that, we are going to have a wet lab workshop for our various corneal surgeries in our National Ophthalmic Surgical Center. So I can see that this encompasses the entire gamut of cornea in within 2 to 3 hours of can say very comprehensive, compressed learning of these diseases and disorders. So going to start with the first session. I would request Dr. Radhika to take over the first session.
Thank you, sir. Good morning, everyone. So the first session is on corneal ectasia. The first concept that we would like to cover is corneal imaging for diagnosing subclinical ectasia, for which we have Dr. Sridevi Nair to give the lecture. Sridevi is assistant professor presently at RP Center in Unit 3.
Thank you, ma'am. Good morning, everyone. And I'll be speaking about corneal imaging for diagnosing subclinical ectasia. So the terms foamophrastic keratoconus, subclinical keratoconus, and keratoconus suspect have been used interchangeably to denote the very early ectatic changes in the cornea before they become clinically apparent or even on topography, as in the case of foamophrastic keratoconus. So the screening for subclinical ectasia has progressed and improved over the years, starting from the topographical indices that we used first, then to the tomographical indices, and now to the combination of biomechanical and tomographical parameters, which are extremely sensitive in diagnosing subclinical ectasia. So the first tomographical device that we'll discuss here is the Pentacam, which is the most commonly used, and it is based on the Scheimpflug principle, and it computes a three-dimensional reconstruction of the cornea for both, including both the anterior and the posterior surface. So the Pentacam chord map is a very important map when you screen for subclinical ectasia, and it is composed of four other maps: the Axial Curvature Map, Anterior Elevation Map, the Pachymetry Map, and the Posterior Elevation Map. So first, let's look at the axial curvature map, which actually gives the corneal dioptric power at each point. And what we have to look for in this map is one, any area of corneal steepening, any area of superior inferior asymmetry, and any skewing of the axis. So these are some of the cutoff values for the skewing and the K mean and any inferior superior asymmetry. And this is what an abnormal anterior curvature map will look like on a pentacam. Next, we come to the anterior elevation map, where you get the elevation of the anterior corneal surface in relation to a best fit sphere or toric ellipsoid. And in this case, the elevation of the corneal points relative to this reference surface is calculated, and the points which are above this reference surface are represented in warmer colors. So on the anterior elevation map, when you use a 9 mm best fit sphere, the cutoff for the highest point in the 5 mm zone should be less than 12 micron. Similarly, for the posterior elevation map, this cutoff should be less than 17 micron, and the posterior elevation is a more sensitive map for detecting subclinical ectasia. So the abnormal patterns that are seen on the elevation map include the central island and the skewed hourglass pattern, which can be seen here. So this should be but differentiated from the pattern that is seen in a normal regular astigmatism, where you'll see that the warmer colors are there in the periphery corresponding to the flatter axis, but the center is normal with the cooler colors, as opposed to the central island where you see the warmer colors in the center. Next, we come on to the pachymetry map, which gives the pachymetric distribution of the cornea. So the important points to look for in this map is one, the pachy-apex, then the thinnest pachymetry, the difference between the pachy-apex and the thinnest pachymetry, and the displacement between the thinnest point and the apex of the pachymetry, which should be less than 500 microns. So the abnormal patterns on a pachymetry map are that of a droplet pattern or a dome-shaped pattern, and you will see that the thinnest part is vertically displaced from the apex. So these are some of the cutoffs for each of the four maps that can help you in screening these patients. But these are not sacrosanct values. You should not just go by one single value, and you should look at all of them in totality. Next, we come to the Ambrosio Enhanced Ectasia Screening Display, where instead of using a regular reference surface, which is seen in the first figure, we use an enhanced reference surface. So in the enhanced reference surface, the central 3.5 the 3 to 3.5 mm of the cornea is excluded, so that whatever reference surface you get will be flatter, and this will help you further accentuate the ectatic or the conical protrusion. While this difference will not have much of an effect in a normal cornea, it will definitely show the changes in an ectatic cornea more prominently. So now when you look at the Bellin Ambrosio Enhanced Ectasia display, on the left side, you have the enhanced ectasia maps. So the first one is the map, the elevation front and back with a regular reference surface. The middle one uses an enhanced ectasia reference surface. So you can see it's more prominent, the elevation here, back elevation, also the front elevation. And the last one gives the difference. So this difference, if it is in the yellow zone, that is more than 5 micron for the front surface and more than 12 micron for the back surface, then it is considered suspicious or abnormal. Next, we come on to these two graphs, which are here. That is the corneal thickness spatial profile graph and the percentage thickness of the cornea. So both of them, they show the progressive thickening of the cornea from the thinnest pachymetry to the periphery. And these two lines, the black lines here, they represent the 95% confidence intervals. And in a normal case, the graph of the patient should lie between these two lines. Next, we come on to the various pachymetric indices which are there on this display. The first one is the pachymetric progression index, which describes the increase in the corneal thickness from the thinnest pachymetry to along each hemimeridian, and it is reference to a normal population base. And the Ambrosio relational thickness, which is seen here, it is basically the ratio of the thinness pachymetry divided by the pachymetric progression index, whether it's PPI max, PPI minimum, or the PPI average. So these are some of the cutoff values that have been proposed for ART max, which is around 400 microns. Now this differs from study to study, and this PPI average, again, it should be usually less than around 1.05 to 1.2. Then we come on to the most important index in this display, which is the D value or the bad D index. It is a multimeric index which is composed of these 9 tomographic parameters, and it is a single value which will help you differentiate between normal corneas from that of ectasia. So a cutoff value of 1.6 gives a 84% sensitivity and 86% specificity to differentiate subclinical keratoconus eyes from normal ones. So now if you look at this case example, we have a patient here who has a Kmax of less than 47 diopter. The astigmatism is also okay. There is no skewing in the right eye, very minimal skewing in the left eye. But if you look at the pachymetry for this patient, the thinnest pachymetry is around 482 microns in both eyes. And in the right eye, you'll see that the displacement of the thinnest point from the center is around 630 microns, which is abnormal, and it's 480 microns borderline in the left eye. Also, you can see these two islands here on the posterior elevation map. So even though the value of posterior elevation is below the cutoff of 17 micron, but if you see that it corresponds with the area of thinnest pachymetry as well as the inferior temporal location, which is where the cone usually starts forming in keratoconus. Now, if you look at the bad display for the same patient, you see that the ART max is reduced at 355 and 326, and also the D value is increased for both eyes, which suggests that this is a case of fumifrostic keratoconus. Similarly, you look at another case example where you see that the Kmax is quite normal, 44.6. There is no skewing of axis, and the thinnest pachymetry also seems to be quite normal at 523 microns. The bad display shows a normal D value. But if you look at again the thinnest, the displacement of the thinnest point, it's around 663 microns, and there is a localized elevation or island of elevation on the posterior elevation map, which corresponds to the thinnest pachymetry. So this makes this case suspicious, in addition to a reduced ART max and a borderline PPI average at 1.12. So now when you look at the fellow eye of the same patient, it's a case of frank keratoconus, which makes the diagnosis for the first case a case of formifrostic keratoconus despite having a normal D value. So what we're trying to emphasize with this case example is that you should not depend on a single index to diagnose FFKC, and you should use a more comprehensive approach using all the indices and parameters. So while the tomographic evaluation did improve our sensitivity at diagnosing subclinical ectasia, we were still missing out cases and patients were still developing ectasia despite having a normal tomography. This came in the biomechanical evaluation. So the corneal biomechanical changes occur before tomographic or other topographical changes in cases of ectasia. And Corvis is one such device which allows us to utilize the corneal biomechanics in screening and detecting early ectatic changes. It combines the air pulse tomography with ultra high speed Schimflug technology such that it directly assesses the corneal deformation process in response to an air pulse. So the cornea, it undergoes a process of deformation when an air pulse strikes it, and it goes first to a phase of first applanation, followed by a phase of highest concavity, and then it returns to its normal phase after passing through a phase of second applanation. So there are three important displays on the Corvis device for screening of ectasia. First is the dynamic corneal response display. Then we have the Vinsigras screening display. And then we have the ARV or the Ambrosio Roberts Vinsigras display, which is also a combination of the tomographic and biomechanical parameters. So the DCR display, essentially, it displays the time, length, velocity, and amplitude parameters, which are derived from the corneal deformation process when it's hit by the air pulse. And in addition, it also has the various shape parameters which are calculated in the phase of the highest concavity. The issue with these parameters is that they are highly sensitive to the intraocular pressure, and the values, there are no clear cutoffs for them. They are very confusing. So it really limits their ability to be used as screening indices for diagnosing subclinical ectasia. Thus came the Vinsigras screening report to mitigate this issue, where we have these four biomechanical parameters in addition to the two indices, CBI and SSI. So in addition to giving the value of these parameters, this display also gives the normative database value in 3 standard deviations above and below, which allows us to interpret them better and detect any abnormality in our patient. So first, let's talk about the Corvis Biomechanical Index, or the CBI. It is a single index which is there on the Vinsigras screening report. It is derived from 5 other biomechanical parameters, and a cutoff of 0.5 has been found to be quite sensitive for diagnosing frank ectasia. Its role in diagnosing subclinical ectasia, however, is limited. Next, we come to the stiffness parameter, which is the first index that gave an estimate of the global stiffness of the cornea. And as suggested by the term itself, it is the ratio of a resultant pressure on the cornea divided by the displacement of the cornea. But this pressure, it takes into account the biomechanical IOP, which makes it less dependent on the IOP as compared to the earlier DCR parameters. So that drawback is not there with this parameter. So a lower value of SPA1 or SPHC indicates a less stiff corneal response or a less biomechanical strength. Next, we have the stress strain index on the Corvis, which again is a term which gives the overall corneal stiffness, and as compared to the stiffness parameter, it is considered to be independent of both IOP and the corneal thickness. So it may give you a more accurate depiction of the corneal stiffness, and the value of 1 is taken for the average experimental behavior of a 50-year-old cornea. So anything less than 1 is considered to be softer, and anything more than 1 is considered to be stiffer. Next, we have the Arv display, which combines the biomechanical and the tomographic assessment of the cornea. In this, we have the tomographic biomechanical index, or TBI, which is computed using an artificial intelligence approach, and it is found to be highly sensitive to diagnose subclinical ectasia. A cutoff of 0.29 gives a 90% sensitivity. So TBI has been found to be superior to BAD-D and CBI in diagnosing subclinical ectasia. So when you look at some of the Corvis ST
30
parameters,
seconds left, Sridevi.
yes, sir, TBI and SPA1 have been found to be more this thing as compared to your CBI and TBI. Next, if we come, I'll just skip this case. Next, we have a case here where the Kmax for this patient is around 46 diameter with inferior steepening, and the pachymetry is around 500 microns. The displacement is okay, the BAD-D is normal, and the PPI is normal. But the ART max is a little borderline in this case at 363. If you look at the left eye, we have again a similar picture where the K is showing a little inferior steepening, but again the BAD-D is normal with ART, which is borderline. When you look at the biomechanical assessment of this patient, you see that the SSI is reduced, the SPA1 is reduced, and the CBI and TBI are both abnormal or borderline, which again suggests that this is a case of foamifrostic keratoconus. So this shows the importance of biomechanical assessment in case of borderline tomographic cases. Next, if you look at another imaging modality is the anterior segment OCT, where the epithelial mapping can help us diagnose subclinical ectasia, and an epithelial donut pattern which shows a localized thinning with a surrounding area of thickening is characteristic. So this is a case with the right eye keratoconus, and the left eye the patient has a foamifrostic keratoconus with a normal topography and as well as tomography and normal D value. If you look at the ASOCT epithelial mapping, you can see a localized area of epithelial thinning with a surrounding area of thickening, suggestive of early ectatic changes or FFKC. So to summarize, using both tomographic and biomechanical parameters in a combined manner helps in improving the detection of subclinical ectasia as compared to tomography alone. The BAD-D, TBI, and SPA1 have been found to be more sensitive in differentiating subclinical ectasia from normal eyes, and ASOCT is a useful adjunct in these cases. Thank you.
Thank you so much, Sridevi. What we'll do is we'll keep questions and interactions at the end of the session. We'll have the next lecture on halting the progression in ectasia by Dr. Manpreet Kaur, who is also assistant professor in Cornea Unit 3. And all of you are encouraged to, submit some questions. There might be some papers which are being circulated, or you can just, tell Ayush if you have any questions so that we can compile them and take them at the end. We are waiting for Manpreet to set up. Any comments, Dr. Namrata or Dr. Titiara?
I think it was an excellent presentation, Shridevi. Only thing is, I think you can answer now, maybe later. Preet is already ready. What about the ABCD progression that has been described? I think we can, Shridevi, we can take that later.
Good morning, everyone. I'll be talking about halting progression in ectasia. Second. There are no financial disclosures. So keratoconus, as we all know, is a non-inflammatory bilateral progressive ectatic corneal disorder characterized by progressive thinning of the cornea. So there is a window in which collagen cross-linking can be used to arrest progression of ectasia in progressive disease with corneal thickness ranging around 380 to 400 microns. Below that, generally cross-linking is not effective. So indications are keratoconus with documented clinical progression with a perceived risk of progression post-refractive surgery ectasia or keratoconus with previous other forms of corneal surgery. What's important is that you have to document clinical progression or a perceived risk of progression has to be there. So how do you define progression in ectasia, which is the first step? So different authors describe different criteria to monitor progression. Global consensus on keratoconus and ectatic disorders define progression as a consistent change in at least two of the following parameters above the normal noise of the testing system. So what it took as significant is a progressive steepening of the anterior corneal surface, posterior corneal surface, and progressive thinning and or an increase in the rate of corneal thickness change from the periphery to the thinnest point. Of importance, change in a best corrected or uncorrected visual acuity was not a prerequisite as per this consensus. Then different criteria have been described by various studies. The original Dresden protocol described increase in Kmax more than equal to 1 diopter, self-reporting deterioration of visual acuity, and a need for new contact lens fitting for more than once in 2 years. Similarly, studies have described 6 months criteria based on 6 months, 18 months, or 24 months changes. And as you can see, 12 months, 4 months, 6 months. What we take here is increase in Kmax corresponding to a change in subjective refraction more than equal to 1 diopter or a 5% decrease in the thinnest pachymetry in the preceding 6 months. So more than any absolute value, what is significant is you consider the age at presentation. Pediatric cases, you may consider collagen crosslinking even at initial presentation because otherwise they often go into high drops. Younger age, you have a lower threshold for CXL. Late 20s, 30s, you can defer CXL and just observe even if it's on the borderline. So what exactly is collagen cross-linking? It was initially described by Wolensek et al. In 2003. So riboflavin phosphate and UVA radiation lead to photopolymerization and generation of free radicals, and intrafibrillar and interfibrillar carbonyl-based covalent bonds are created. So the dual function of riboflavin is one, it creates cross linkages in collagen to increase the strength of the cornea and enhances the absorption of UVA radiation to prevent damage to corneal endothelium lens and retina. So it leads to an increase of corneal biomechanical rigidity to the tune of nearly 300%. So the conventional collagen cross-linking technique was described in the Dresden protocol, in which you first do an epithelial debridement in the central 7 to 9 millimeter, which can be mechanical or alcohol assisted, 0.1% riboflavin phosphate and 20% dextrose. One drop is instilled every 5 minutes for 30 minutes, and it's a photosynthesizer for the production of oxygen free radicals. And then ultraviolet light 370 nanometers is put for 30 minutes at the 3 milliwatt per centimeter square to generate a total fluence of 5.4 joules per centimeter square. So as you can see the process on the left hand side of the screen, you can use a well, I have used a reverse stripine to put ethanol and help in the epithelial debridement, and central 7 to 9 area is debrided. Then you put the riboflavin to saturate the corneal stroma for half an hour, and this is followed by application of UVA light, during which also you put riboflavin. So insert BCL at the end of the procedure because you have removed the epithelium, and the depth of demarcation line can be beautifully visualized on an anterior segment optical coherence tomography in the post-operative period. So what it leads to, the collagen cross-linking, is apoptosis of keratocytes in the anterior stroma. New keratocytes migrate from the periphery to the center. There is collagen compaction. Subepithelial basal nerve plexus is obliterated, which starts to regenerate after 7 days. So long-term outcomes of conventional CXL have been extensively studied. There is a reduction in the mean keratometry, improvement in topography, wavefront, reduced mean spherical equivalent, improvement in visual acuity. So the average reduction in spherical equivalent is approximately to the tune of 1 diopter, approximate 2 diopter of keratometry flattening. And in fact, the parameters continue to improve after 7 years. Of importance, progression of keratoconus may occur in about 8% of cases despite cross-linking. Now, what to do in thin corneas? The prerequisite for cross-linking is that the corneal thickness has to be at least 400 microns after removal of epithelium in conventional CXL. So, various alternatives have been used in thin corneas: hypoosmolar riboflavin in buffered salt, trans-epithelial CXL, custom epithelial debridement, contact lens assisted CXL, and stromal lenticule assisted CXL. So various riboflavin solutions are available. So the conventional riboflavin dehydrates cornea up to 60%. In HPMC, the dehydration is less, 10% if you use riboflavin and 1.1% HPMC. Hypoosmolar riboflavin leads to corneal swelling of up to 10% in vitro. And enhanced riboflavin enhances the penetration when you're doing a epi-on or contact lens assisted CXL. So hypoosmolar corneal cross-linking, the osmolarity of isotonic riboflavin solution is 402.7, of hypoosmolar is 310. So there's a corneal swelling, which should ideally be assessed on table using ultrasonic pachymetry or IOCT before you start UVA application. The concerns with hypoosmolar CXL is there is increased endothelial toxicity risk and a reduced treatment efficacy. It is not as effective in corneas less than 330 microns, even if you induce artificial swelling. Transepithelial corneal cross-linking, the limitations of epithelial off are postoperative pain, gradual visual recovery, risk of infection and corneal scarring, and the limitation of corneal thickness. So these can be taken into account and obviated with transepithelial CXL to some limit. So epithelial on CXL, riboflavin penetration through intact hydrophobic corneal epithelium is difficult. So various enhancers are present to enhance penetration, including benzalkonium chloride, EDTA, etc. Now the outcomes, the efficacy is not as well established as compared with conventional epi-off techniques. Some studies show an improvement in visual acuity and keratometry. Demarcation lines is shallower in the transepithelial group. Customized epithelial debridement has been described, in which a small localized area of corneal epithelium corresponding to the thinnest area over the apex is left intact while deepithelialization before CXL. It spares the stroma underneath the thinnest point from the CXL effect. That is one of the major limitation. Contact lens assisted CXL, again oxygen diffusion is hindered by the contact lens and it has a decreased efficacy as compared to normal CXL. Tailored stromal expansion with refractive lenticule for cross-linking the ultra-thin cornea has been described. It's safe and effective in ultra-thin cornea. Demarcation line ranges from 280 to 300 micron and has shown corneal stability on topography. Does require further work. Now we have accelerated and high fluence CXL, which has significantly shortened the time duration required for CXL. It's based on the Bunsen-Roscoe law of reciprocity, that the photochemical effect of a radiation is proportional to the total energy delivered, irrespective of the intensity and total time delivery. So it is as safe and as effective as conventional CXL. And however, for higher energies, 30 milliwatt per centimeter square, there is a reduced efficacy because there is a depletion of oxygen in these high fluence treatments. So now we come to the requirement for oxygen at an adequate concentration in the stroma, which is necessary for CXL. And high irradiation with short irradiation time settings lead to higher oxygen consumption and decreased treatment efficacy. So what has been described is oxygen enrichment of the environment and pulsed accelerated CXL, in which in 8 minutes exposure there is 1 second on, 1 second off, which gives time to replenish the oxygen at the ocular surface. Customized topography guided cross-linking has been described, in which an asymmetrical treatment zone centered on the area of maximum corneal steepness is planned, and it has a potential to improve the corneal shape in keratoconus. Complications, we all know: pain, keratitis, persistent epithelial defect, corneal opacity, edema, and endothelial damage may occur. Just to summarize, corneal cross-linking at present is the only effective modality to halt progression in ectasia. To halt progression, first you need to document progression and the need for CXL and then halt it. Document progression, various guidelines are present to define progression. Evaluate change in at least 2 parameters over 6 to 12 months. Do not rely on any absolute value alone. Take into consideration your clinical experience, and age is an important consideration for decision making. To halt progression, conventional CXL we all know is safe and efficacious. Riboflavin, hypoosmolar, enhanced additives, various formulations are available. UVA, fluence and duration, now we have accelerated CXL and customized ablation is coming up. Oxygen, we increasingly recognize the role of adequate oxygen concentration on the ocular surface, and pulse CXL with oxygen supplementation is catching up. Let's see how it fares. And epithelium on technique customized debridement has been described. Thank you for a patient hearing. Future direction may include a customized ablation patterns for all.
Thank you, Manpreet. That was a very nice overall a comprehensive presentation. Since these two topics are related, before we go to the lecture on acute eye drops, we can take a few questions now since the Sridevi's and Manpreet's lectures are related to ectasia. So are there any questions from anybody? Can I ask one question, Manpreet? What is the youngest child you've treated? Because recently I had a 6-year-old and I was really, wondering how you traumatize them so much with the epithelium off, and I elected to do epithelium on as the first stage, which may be a little out of the box, but if such a small child, the patients go through so much of trauma for the first 2-3 days. It can be even adults are literally sometimes crying with the pain. So I just wondered, have you ever treated a child that young?
8 years, 8 to 10 years, so regularly. I think even younger than that.
4 years. We had
4 years. And how did you manage the post-op
No,
pain,
general-
etc.? No, general anesthesia, ठीक
So
है, but
post-op
what
pain,
about the
you have to
post-op?
basically counsel this thing and give syrup, ibugesic. I mean, you have to give analgesics in that form. We had a whole thesis on it, 116 eyes, pediatric keratoconus, and the youngest child there was
4 years. And did you document the post-op pain and the pain score and how many days,
pain score.
etc.?
We did not document in that series because that was not the mandate. But yes, I think the younger children do. There is a problem with it, but I think with proper counseling and ultimately you do have to do them because they would
Sure.
otherwise progress.
Any question? And Devi, one question there that yeah, sir, you want to say something?
Regarding this, CXL regression, which happens in some cases, as Dr. Manpreet are talking about, 8% people may require, repeat CXL in a series. Dr. Namrata, can you clarify in terms of age-wise? Suppose we do a CXL younger patient, less than 10 years, but there are people around 20 years. Would there be some significant difference in terms of the actual achievement of cross-linking and a subsequent regression in these cases?
So repeat cross-linking is always more in cases of children because the collagen, it depends actually on the collagen turnover, which turns around at around 7 to 8 years. So we would expect that around that time, even in children, in our series also, we had to do a repeat cross-linking. I mean, patients came in for repeat cross-linking almost in 12% of the cases. Also, it depends on what type of cross-linking you've done. In our series, again, the cases which had undergone accelerated collagen cross-linking, you have to do more repeats. And then it's better to repeat with the conventional cross-linking rather than going on with the accelerated cross-linking. I think one factor that I want to bring out, sir, is that apart from age, gender is also an important thing where you would do cross-linking because in childbearing age, especially females, during pregnancy, the keratoconus progresses. So probably if I wouldn't wait in a female to document, especially in teens to document progression. I would just go ahead and do it.
One thing for people who have regression is also depends whether you've adequately controlled the modifiable risk factors. So that's one thing which, if you straight away always treat at point one without taking care of modifiable risk factors, those are the ones who are more likely to require. So this is something which needs to be taken into account and you need to counsel them accordingly.
I think in children, the risk of further progression or the requirement of a repeat CXL will definitely be higher, because if you do somebody CXL at the age of 6 years or 8 years, there's one spurt, there's one risk of chances of change at puberty. So that is one thing. The second thing is that many of these children, not all, I must say, but many of these children do have some element of VKC. So the effect may not be as good as somebody who is having an absolutely quiet eye. So these factors have to be considered in pediatric keratoconus.
So-
But yeah,
So in our cohort of 116 eyes, almost 45% had VKC. And I think we tend to get more keratoconus associated with VKC as compared to the Western world, which doesn't get that much VKC.
I think one clarification can be given for a post-op treatment for these patients, immediate post-op and subsequently.
So, sir, I think immediately
But-
post-op. Immediately post-op.
Dr. Parful?
One thing I would like to highlight here, even now we have a patient of post-CXL keratitis admitted here. The problem with CX patient is if you go through the public literature, Rohit Sethi et al., as well as from our center, most of these patients are resistant to moxifloxacin. The incidence of moxifloxacin resistance was 100% in the case that we have reported from here. And in Rohit Sethi et al., it was almost 80%. So should be a debate whether we should continue Vigamox as a post-op regimen routinely in our Excel patient, or we should change that. But over last 2 weeks, I think I have seen 2 cases of post-Excel keratitis, which is not acceptable because we are doing simply in a naive cornea this procedure. So that I don't know what's the take of panelists, but I think moxifloxacin resistance is quite high in this group of patients.
But that's okay, Praful, but we do so many, I mean, across all the entire center. I'm not saying that that's not acceptable at all, but I think we need to look at the entire data. But as of now, we are giving moxifloxacin only because of the fact that it is preservative free and because of the fact that, I mean, what would you change to levofloxacin?
Yeah, I
1.5?
think that is one concern. Levoflox, you can go 1.5%. Maybe that would have a
Yes.
effect. Second is, because you have a epithelial which is debrided in these cases, and healing is going to take more time compared to other group of refractive patient where epithelial healing happens very fast. And there are always chances of having keratitis in these patients because of poor, you can say, the health of a cornea as such. So you're right. We do require a good prophylactic antibiotic to cover that area. And most of these cases will have a bacterial infection to begin with. There are some cases where fungal infection has been reported in these group of cases. So both things has to be taken into consideration. The only thing which we have been debating is, should we start steroids in these patients immediately after cross-linking, or you wait for a time till the epithelial defect heals in these patients? In the meantime, that is a window period where you have to look into. I don't know. I think the protocol is to start steroids after epithelial defect heals in these patients.
Yes, that is the universally accepted protocol right now.
Yeah.
You should start steroid only after epithelium heals.
Yeah, Dr. Banati.
Yes, so just one question, because when you're looking at patients who are 4 years and 6 years, how do you go about the corneal imaging for these cases, for the steepening, and how do you look at the postoperative imaging and pachymetry? Is it just on the table keratometric evaluation and a pachymetric evaluation? Because the topography in such
I know that
small children is really, and again, imaging of corneal imaging by topography in children has a very high variation rates between intra-observers and inter-observer variations here. So that's one factor which we need to consider. And I think, as rightly pointed out, association of VKC. And most of the time when we do see them, their corneas are thinned. And when you look at their eligibility for doing a repeat enhancement in these, most of them have gone beyond the safety factor of pachymetry for these, and you probably will have to consider to take them on for an early dark, considering that these corneas have been steeper than in the normal population given the age.
Okay.
One
you
more
so
point, sir, as you were talking about steroid. Uh, uh, Recently, of late, for the last 3-4 years, we had so many cases of cross-linking in some of the thesis also. And what I figured out was that many of these patients, I mean, some of these patients, they had a clear cornea, and then they developed late haze. Then I thought I will, send it as a case series or something. Then also it was there that late haze can be seen. So I think after complete epithelial healing, what I do now is that I keep putting steroid on a very long-term basis, maybe once a day, but for very long term so that haze doesn't appear. Okay.
Thank you, Rajesh. Can we go ahead now? So we come to another very important aspect of keratoconus, that is acute eye drops. And the management of this condition will be covered by Dr. Priya Darshini, who is a senior resident in the Cornea Unit 4.
Very good morning to one and all present here. So I'll be covering about the management of a case of acute eye drops. It is a relatively rare complication which is seen in cases of corneal ectasias. The incidence has been reported to be about 3% in keratoconus, and pellucid marginal degeneration it is reported to be about 6 to 11%, and in keratoglobus about 11%. In it has also been reported rarely in cases of marginal degeneration, LASIK and radial keratotomy associated keratectasias, and post-JALK in PKP patients with keratoconus. So what happens here is there is a tear in Descemet's membrane which leads to leakage of aqueous humor, and then that results in stromal and epithelial edema. So what causes it? It has been reported in varied ages between 12 to 66 years. Men are more commonly affected over women. And the risk factor for it is mainly the earlier onset and diagnosis of keratoconus with a steeper keratometry at presentation and a poor visual acuity at diagnosis. The main risk factor causing it is eye rubbing, which causes trivial trauma in these ectatic eyes, which is usually associated with VKC and atopic disorders. And in some patients with Down syndrome, because of mental retardation, they tend to rather rub their eyes more often. So the patient usually presents with epiphora, photophobia, pain, and diminution of vision. The signs are diffuse conjunctival hyperemia, diffuse stromal edema, and microcystic epithelial edema. And intrastromal cysts and clefts have also been seen in some patients, in which there has been a large fluid accumulation. So the grading of acute eye drops has been given by Miata et al. And it has been graded into three categories. Grade 1 involves within 3 millimeter diameter of Descemet's tear, and between 3 to 5 is grade 2, and anything over 5 millimeter is grade 3. So the sequelae is it causes significant corneal scarring if left untreated, and neovascularization. It can lead to secondary infections, pseudosis, malignant glaucoma, and perforations have also been reported in some cases. So how does it resolve on its own? There is eventual reattachment of the Descemet's membrane, and eventually the endothelial cells around migrate over the posterior stroma, and the defect closes down. And the spontaneous resolution depends on the depth of the detachment of the Descemet's, the dimension of the break, and as well as the size of the break. So the larger the depth of detachment and more the number of intrastromal cysts, the longer it takes to resolve on its own. The spontaneous resolution has been reported up to 2 to 4 months after the onset of acute eye drops. So this is a case of acute eye drops which presented and then it was resolved spontaneously. You can see that there is very dense vascularization here after spontaneous resolution, and this means that there is a lesser chance of survival of a subsequent graft in these patients for visual rehabilitation. This was a case of acute eye drops that had perforated and was then treated with glue BCL for the time being. So the basic investigations that you need to monitor the progression of the disease is ultrasound biomicroscopy and ASOCT. In vivo confocal microscopy is also being used to study the pathophysiology of this disorder, though it doesn't have much of a significance in monitoring the progression. So in ultrasound biomicroscopy, we can note the different characteristics of the acute eye drops, like the level of Descemet's tear, the orientation, and if intrastromal cysts are present, the number of cysts, the size of the cysts, the communication between them, if there is any fistulous communication between the AC and the cyst. And the main disadvantage is that it is a contact procedure. And hydrops resolving index has been has been described by Sharma et al. In her paper. In and it is the ratio of the maximum thickness of corneal edema, and it is uh, it is divided by the thickness at a distance of 2.5 millimeter away from the maximal distance. And as the hydrops resolves, this index increases, and that can be used as a way to monitor the hydrops. ASOCT has the advantage that it provides better resolution and it is a non-contact procedure. It can also document a clearer view of the intrastromal clefts. And so this was a case of a child with keratoconus who presented with acute hydrops. Initially, you can see that there is a huge intrastromal cleft over here. And the child was treated with intracameral gas injection, and you can see the progressive changes in the ASOCT as well as the clinical photographs. And by 1 month, this child has resolved. This image is in contrast with the image that had resolved spontaneously. Here you can see that there is very less vascularization because of immediately treating the patient. And this kind of a picture would eventually give to a better prognosis in cases of treating the patient later on with keratoplasties. So in vivo confocal microscopy literature, there have been studies to know about the pathophysiology of acute hydrops. Like I said, it doesn't have much of a use in the, monitoring the progression. And here you can see that there are prominent bullae mainly in the superficial part of the epithelium. And there are hyperrefractive round cells in the epithelium and in the stroma. And in the initial phases of the hydrops, they noted elongated branching cells which were smaller in size, which then became slightly larger and more speckled as the hydrops was resolving. So the goals of treatment is to improve the patient comfort, speed the time for recovery, and thus minimize complications and restore visual acuity in a patient with acute hydrops. So for patient comfort, we give them topical preservative-free lubricants, a pressure patch or a bandage contact lens, topical hypertonic agents to reduce the edema, topical steroids to reduce inflammation as well as reduce the risk of neovascularization, topical antibiotics to prevent secondary infection, especially in cases where there are epithelial defects, cycloplegics to reduce the pain, and topical IOP lowering agents. Some studies have also reported the use of topical or subconjunctival anti-VEGF in decreasing the risk of vascularization while the healing process occurs. So surgical management involves pneumodesmatopexy, in which SF6, C3F8, C2F6 have been used. And along with it, some have also used compressive sutures, stab incisions, micropunctures, and eventually you will need a keratoplasty for visual rehabilitation in these patients. So in pneumodesmatopexy, basically we inject air into the anterior chamber intracamerally. So that prevents aqueous penetration and direct contact of the aqueous, and it prevents the seeping in of the aqueous to form these intrastromal clefts. So this will promote reattachment of the Descemet's membrane. It stretches the rolled out edges of a Descemet's break, especially in cases of slightly long-standing hydrops, and it will promote the migration of the endothelial cells. So in the technique wise, you need to constrict the pupil first with pilocarpine, make a paracentesis and remove 0.1 to 2.2 ml of aqueous humor, and then we go ahead with injecting the gas, and we leave the gas up to 2/3 of the anterior chamber to prevent any chances of uh, pupillary block glaucoma. And we also do a PI if needed, and supine position is advised for a couple of days. So compressive sutures have also been advocated along with pneumodesmatopexy by in some studies, and this is basically more useful in cases in which there are large intrastromal clefts. So the sutures are placed at a 90-degree orientation to the Descemet's break, and 4 to 5 sutures are placed, and these are usually removed after 2 to 6 weeks. So this reduces the time to recovery, especially in cases with large intrastromal clefts. It helps the removal of the fluid, and it helps in better Descemet's attachment. Sorry. And it also prevents recurrent need for intracameral gas injection. So Vajpayee et al. Had described the use of stab incisions or micropunctures. In this, we give 4 to 5 stab incisions, and these stab incisions can again help in egress of the fluid and help in faster resolution in cases with large intrastromal clefts. This will circumvent the problems related to suture removal in these cases, in cases in which compressive sutures are used. So this is just a case in which IFC with hydrops was reported. This patient had a steeper cornea, presented with acute hydrops with multiple intrastromal clefts. So we are making a paracentesis and injecting intracameral gas, making multiple venting stab incisions at 45-degree angle. And you can see the egress of the fluid, and it is being removed with Mirocil sponge. You can see in IOCT that as the fluid is coming out, the pockets are gradually reducing in size. And now the cornea has become almost compact, and some of the gas has been egressed out, and the port has been hydrated with basis. So this was the 1 week post-op image after gas injection with stab incisions. So other methods like amniotic membrane transplantation with cauterization has also been described in some studies. So the take-home message is that early management of hydrops is a mandatory thing to prevent later complications and decrease the neovascularization, and also enhance the time to recovery. And enhancing the time to recovery would give better patient comfort, and it also gives a better chance of survival of a graft when we plan a later keratoplasty. Thank you.
Thank you very much, Priyadarshini, for a very nice presentation. Are there any questions or comments from any of the faculty?
I think she covered almost everything, except that now people, I mean, there is a group which does talc even in acute hydrops. We don't do it, but I don't know whether it makes any difference if you do it early. The size of the scar is supposed to be less, but intraopacity microscope has really made our life easier, because you can actually see those clefts and cysts and give your stab incisions appropriately. And when you give those stab incisions, the fluid comes out. You also have to do a little bit of external massage, because just by giving a stab, it doesn't come out. So just like in dissect, you do an external massage, you have to actually massage the fluid out of those clefts or out of those spaces. And in these cases, later on, I think is important. You can do a layer by layer DALC, especially if the area of the hydrops or the scar is paracentrally located, and without having to do a full thickness penetrating keratoplasty, these patients can also be rehabilitated. And I think Dr. Rajesh would also agree that sometimes you can even do a better contact lens fitting in these cases, because the scar moves paracentrally.
जोर से बोला.
Press the button, please.
चल रहा.
Acute hydrops, that led to perforation. So was it because of secondary infection that led to perforation wherein glue BCL was done?
Yes, that was a case of post CXL. The patient had infection, and on next day we noted that there is hydrops also, and that was reported also by us.
So we've
So it
reported
was a
that.
post CXL keratitis patient developing hydrops. Exactly what was the cause we didn't know.
And then the infection further progressed and led to perforation.
No.
No, it was the
Post
other.
CXL infection was there on day one. On day two, we noticed there is a hydrops.
Yeah.
So we did a glue BCL, and with antibiotic only the patient healed with that only. The exact cause we don't know why there was hydrops. Maybe due to I don't know, but infection precipitated that.
No, I couldn't get your point.
CXL was done. Next day, there was a patient presented with infection. So we admitted the patient.
And
On the
with
day
eye
2,
drops.
there was a high drops.
And with eye drops.
Okay.
So we
So,
reported this, that this can
no,
also.
but she showed that was a patient.
Yes. Subsequently, it melted.
Melted. That's
Yeah.
got.
So, Priyadarshini suggested that we should operate in all cases. Is that your message or what? You said, no, if you do surgery, then this chance of subsequent graft survey, everything is
Prabhu,
good.
you can tell her in what cases you will not operate.
No, she will tell.
You will tell.
No, this point is valid. If you look into literature, in the past, acute hydrops was a medical management. It is now we have understood the disorders, especially in the hydrops, where after seeing the DSEC, DMEC surgeries and looking into our corneal dynamics, intracameral dynamics, which we could see with the IOCT, the things have changed so much. And the concept of a simple medical treatment has really gone into background. There will be very few cases where we might consider a medical treatment, like a patient who is not fit for a anesthesia, sometimes very young patient, Down syndrome, where things can be difficult. You might conservatively treat those patients, though it might heal again with a scar, but the time duration taken, as you rightly said, will be very, very long. And that is the period our patient and the family will be in a great agony and pain. That can be decreased by a surgical intervention, which is now become very simple. Intracameral air or gas injection has really decreased the rehabilitation time or treatment time in these patients. Yes, there are a few cases where you can definitely think of like a small decimal tear, very few pockets, and it's paracentral areas. You might consider a medical treatment, which is basically steroid and mediatic sometimes in these patients. And classically seeing, if you look into literature, now the newer literature is all based on these procedures. In fact, as Dr. Namrata pointed out, people are jumping to do a, DALK in acute hydros patients just to decrease the, rehabilitation time in these patients. We are not sure what is the outcome of DALK in these patients as compared to a patient which would heal with the hydros and do a subsequent procedure. So those two things will be totally different in terms of outcome wise. Yes, Parfur rightly pointed out, medical treatment is a possibility and people do it also. Not everybody will jump into a poking needle inside a anterior chamber in many, many cases. And in fact, what Parful can say, published this, acute hydrops happening after CXL and complicated by infection is one of the rare case to have a reported hydrops after, a CXL treatment. And there are, I don't think any such literature where after CXL hydrosis occurred in these cases. There are some cases where they've done intracorneal ring segments. There, the reported hydrops are there. But this is a unique case after CXL having a hydrops. I'm not sure if you two have seen some cases.
Two more cases where post CXL we've had eye drops.
So this is a question mark there, no? After doing a CXL, even then you have a hydro, that means the CXL was not effective enough in those cases. Either the cornea was thinner in these cases or the disease was progressive, or as we discussed, patient having a BKC type of disorder where they keep rubbing their eyes. That may be another compounding factor for a, can say, progression of disease in these cases. Any other questions from the
What was
audience?
the age of those patients, ma'am, which you were telling
They
that
were young.
they-
One patient was referred from outside.
did they have any associated VKC?
One patient was referred from outside and was primary keratoconus, and the other had VKC. But the patient was older. The patient was 20 plus, the one who had VKC.
Sir, can I, sir? Just to add on to what you had already said on medical management versus going intracameral air injections, I think there has been a comparative evaluations. So when you do air injections for hydrops which are presenting within 10 days of onset, then an immediate air injection intervention helps in rapid resolution of these cases and early visual rehabilitation. But when it goes beyond, the hydrops has been present beyond 2 weeks, the comparison of a medical versus an intracameral gas injection has shown a equivalent time of healing in these patients. Also, I think there is a latest literature which is recommending a modified compression sutures technique in which they do a combination of paracentesis, anterior chamber decompression, air injection, compression sutures, along with bandage contact lenses for refractory or long-standing hydrops, and have claimed it to be best in terms of early visual rehabilitation.
There's a case report of DMAC also for.
Thank you. With
I
that,
think we covered the initial segment of corneal ectasia, and I can understand corneal ectasia as such is an entire one-day workshop, and we could cover the very important aspects of early diagnosis of ectasia, which is so important not only for looking into a treatment of a CXL in these cases, for other purposes also, refractive surgery point of view also. We should be aware of picking these patients before we actually diagnose them as a early keratoconus. That means before there are some suspicious points which we discussed and nicely pointed out by Dr. Sridevi. Even going through all these indices, it takes 1 hour, but covering them in a 12 to 15 minutes is an expert's job, and she is a real expert in that field. And subsequently looking for halting the progression. I know that to halt the progression might take years and years, but we could do it at 10, 20, 12 minutes here. And subsequent discussions by our faculty was definitely beneficial to our entire group here. I can understand we do have people who have come from various parts physically and our own students. And the physical discussion is so important because that is going to last for a very, very long time. So I'll encourage all of you to have some questions ready so that we can answer them. And it's not only for you, it will be beneficial to entire group of people who are going to join today or subsequently going through or, live recordings also. So be, awake and keep asking some questions.
thank you, sir. So with that, we conclude the first session and we go on to the next extremely exciting and useful session called Near Live Surgery. In this, there are going to be a host of faculty who are highly experienced and internationally renowned who are going to show their surgical variations in techniques. To begin with, we'll start with our chief, Professor Tityal, and he's going to cover the demonstration of DMEC surgeries.
Thank you, Professor Radhika. And as we had a terrific session in the morning, second session is on showing surgical, can say, steps to improvise the outcome for these important surgery which is done for our various corneal disorders. Looking into a last decade or so, the endothelial transplant surgery has become so popular, not only because we have a multiple number of patients requiring endothelial transplant, but because the surgery has become simpler in terms of a patient outcome wise, because simpler surgery would give a better outcome for our patients in terms of giving recovery of visual acuity in these patients and maintaining the health of cornea for longer term. In that way, I think no suture surgeries like a DSEC, DMEC has changed the entire concept of corneal surgeries, which we used to do a few decades back. So I'm going to talk about descendant membrane endothelial keratoplasty, commonly known as DMEC. And we all understand we have two common indications in India. One is post-cataract surgery endothelial decompensation or a PVK type of picture. Or sometimes you do have a patient who would have a Fuchs endothelial dystrophy in this age group, which may have been missed by early diagnosis in cataract patients. Or nowadays we tend to diagnose more often than before because we have the advantage of the surgery to improvise outcome in these patients. So as far as surgery concerned, there are four important steps to be seen in these cases. And one is first is the host, because we should understand how to depict the host in a proper manner so that you can fashion the host Descemet scoring, because that's the most important aspect for these surgeries as compared to a DSEC surgery, which I highlight subsequently. And apart from that, if you have a patient, phakic patient, has some cataract, you may have to do a cataract surgery along with or before you do these procedure, and do a peripheral iridectomy inferiorly, which is compulsory in a DMEC procedure. So these are few important steps in these DMEC surgeries. And second important thing is preparing the Descemet endothelial complex from the donor tissue. That is a donor scroll or a roll in these patients. Then loading them up properly, then injecting them inside the eye, and actually making them unfold in a proper manner and attaching them towards the bare stoma in these cases. So let me just show my video here. It's not going to come entirely. Okay, it's coming. So this is one of my patients where I've done a cataract surgery a day before. You can see good capsular axis margin covering the entire lens, which is important. Don't make too larger capsular axis because this procedure, lens might come up and cause more difficulties. All these paracentesis should be little anterior so that bleeding doesn't occur. Though it is a post-op patient, you have a little inflammation happening there. So we would inject sodium hyaluronate, which gives a clarity of visibility and maintains the anterior chamber, and do a Descemet scoring in this patient. Just for a postgraduate students here, it is two things are important for a scoring Descemet in these patients. One is it should be a very smooth scoring of the Descemets without causing damage to the stoma. Second is the size of Descemet scoring has to be larger than the DMEC roll which you're going to prepare by at least 0.5 millimeters. So it is very important because the Descemet may not get attached to the Descemet already there in the host area. So that may be cause for detachment happening subsequently, which is not so important for DSEC patient because DSEC graft get attached everywhere, anywhere. So that is the difference you have to see here, larger scoring area, and use the reverse Sunsi, which is not very sharp and not very long. So this is a shorter and a smoother tip of a reverse Sunski hook. So these are very important, and at one go you should complete the scoring. Make sure sometimes people do a incision later of a main incision so that you don't come to the incision area because that will be difficult to score sometimes. So you can avoid main incision, do a paracentesis incision, then take out. See how effectively this is taken out without too much of struggle. People might do scoring under air, which is also a very good area because the visibility of Descemet improves in these cases. Under fluid is difficult in our DMEC cases. So once you have a complete scroll, you can pull out from the main incision with a reverse Sinski hook. After we have done a complete scoring, next is removal of viscoelastic. And if you use a cohesive viscoelastic, that's going to come out effectively in a one go without leaving inside and doesn't coat the surface also. Never use a dispersive viscoelastic in these cases. So once I have taken out, I have made sure that my IOL diaphragm doesn't come up with a sudden decompression, pielocarbonize it and do an inferior PI. Then inject the air bubble which is missing in this, you can say, edited video a little bit. Inject air bubble now and maintain the air bubble till you prepare the donor roll. That will cause a little bit of oozing, which might happen to the PI area. If there's a oozing, little bit of a heme, that will be a cause of malattachment to your donor roll. So that is very, very important to maintain the stresses in your cases. Now to prepare a roll, you can have various techniques which has been described in literature. You all know that. So these are, this can be manual methods, which we have been doing regularly here. Scuba techniques is the first one described. And a standard traditional technique I'll be showing to you. Then you have a pneumatic dissections, like you have preparation of PDEC. You do for a DALF procedure, you create a big bubble in these cases and then puncture. Or you do a hydro procedure where you have a endothelial up in a trephination, make a around 270, 300 degree trephination, and from the non-trephinated area, you can do a hydro dissection of an entire area to have an endothelium towards your side, and subsequently you can inject in a better manner. If you see, this is our technique. After making a central demarcation, make a light definition of a size, which may be 7.5 to 8.5, depending on the white to white, should be then put a trypan blue dye. It should be there for at least 30 seconds so that the peripheral definitions are clearly visible. Next is take out the peripheral scroll of Descemets and leave the clear edge of a Descemet towards the, the roll which you're going to create. And have a nice hold of a Descemet and just peel it and make sure your field of vision should not only in the center, it should be a peripheral area also, like in these areas, because this is the area which will have additions and sometimes tear can happen. So once you have a 2/3 descent detachment, make a central puncture on the remaining stromal part so that we can mark it towards the stromal area of a descent membrane complex. And take out this operculum up, put a S mark or whichever mark you are convenient with, which can be picked up during your resurfacing of a roll in the inside the eye. Now we punch it, and this is the scroll which we have made, and it is put in a Petri dish now. This is a one more video to highlight. You can have additions also. So once you are peeling off, as I said, your vision should be in the peripheral area because this is the attachment which can cause a tear. You can see this is the attachment here. The other area is, this is clearer. So I would shift to this side and keep detaching the descent. So you have to make sure your field of vision is bigger and make sure you look into peripheral areas where you may have an attachment here. So once you rotate your hand, and you can just peel it off and complete not in the same manner. So this is the advantage of moving your hand in such a manner which gives you a little bit of easy holding of a descent membrane. So once I have done a little bit of dissection of an addition area, then I can still take off now. So this is the way you can complete subsequently, and most of the times the preparation of a descent membrane roll is simpler. Then a subsequent step which I'm going to show in these patients. So these are various ways to, you can see if I look into just to describe this, this is what we have been doing in our cases. You can have you can indigenously prepared, injectors, or you can have glass pipette like this, which we had Gildor, or you can have this type of modified Jones tube. Or this is the latest one from Donald Tan, which is basically a DMEC endoglide, where it is placed in a endothelium down, and you can just pull it inside the anterior chamber like you do for DSEC. So 100% of the time, opening will be absolutely in a right direction. So such things are innovation which helps in a surgery for these critical patients. So this is a IOL injector which we have used in this patient. Make sure this clear part is not colored because I don't have to reuse them. And once you are trying to suck this roll, make sure it doesn't come into this area of invisible areas. And this S should be visible to you so that you can manipulate your injection so that S is visible to us up. So this is, I think, very important for all of us to understand what are the various ways by which you can understand that it's in the right direction inside the anterior chamber. The difference here, apart from DSEC, everything has to be done before you inject the air in these cases. The graft has to be unrolled, unfurled onto the iris surface. Then only you have to inject the air bubble. So these are various signs which will help you to pick up which is the right direction for a DMEC for us. The first one is moisture. This is the IOCT sign, correct way to depict. And this is the moisturous sign, where if you put your cannula, it should be blue. And this is a Minuteman sign, which is again triangular shape. And this is what we have been using in our surgeries. If you have IOCT, you can really pick up the correct way of orientation. So this is the same case. The roll is inside now. We have to tap it to open it. And with the multiple stab incision, you have to just decrease the intracameral pressure by diffusing the liquid or fluid out so that you have a lighter anterior chamber pressure and you can spread the DMAC roll here. So bimanual technique is always preferable. So you can see here, we have a correct orientation of a graft by looking into the orientation of graft here, which is concavity up. And once you pressurize here, shift the graft this side, then open the graft with a gentle massaging or from the anterior side to open it. And fixing from one side is very important. Otherwise, the descent will scroll the graft up again. So once you have a complete opening, you can inject a little bit of air, go up to the paracentral or central area, inject air. If you put a S part, that can also give you the correct orientation of graft. You can see the S mark clearly visible here. So this is a confirmation which can happen in those cases where you don't have access to IOCT for you. And S marking will give you a absolutely 100% accuracy of orientation. This is another case where the graft might open up incorrectly, which we could pick up. This is the initial stage where the roll is complete. It's very difficult to understand it is correctly open or inversely open is difficult to understand. So this is the stage where you have to tap it to open it onto the surface. You can see, if you see here, the orientation of graft is little on a reverse side. So always better to put one suture so that you can manipulate the antechamber better. And if you look into concavity side up, so this will be correct orientation for a graft. So this is the right placement. Make sure this is right in the pupillary area. So this is the inverse opening of a graft. So this is a case where you have to reorient the graft by injecting some more fluid so it flips inside. So this is the easy access of a DMAC roll where you can do a multiple flip inside without having to manipulate by instrumentation. It's just by fluid only. If you look at DSEC, you can't flip inside. So that's the difference in a DSEC and DMAC. So this is what we have done, flipping of the graft and make sure it comes. This is the reverse orientation you can see again. So we'll have to reflip it again for this case. So I'll be again injecting the fluid from the side port because main port is a difficult in these cases. Once I flip it, but you can see the IOCT now. Make sure your assistant or yourself is seeing the IOCT to make sure that it is clearly in the right side before injecting the air bubble. Once you inject the air bubble, then it's very difficult to undo it in our DMAC cases. So this is a little bit of struggle. And from the side port, I'm decreasing the pressure, injecting the air bubble. And you can see graft is well attached. So looking wise, this looks like quite a simple procedure. If surgery goes in the right direction, you can finish the surgery in 10 to 12 minutes. But if surgery goes in a difficult manner, the graft can be spoiled by various means and it becomes very difficult. So this is a immediate post-op picture of a DMAC. Within a month, you can see 30 days, it looks like a normal cornea and difficult to appreciate if some surgery has been done in these cases. So that is the advantage of DMAC as such in all cases where things can be made as simpler as possible for our patients. So that is the advantage of modern technologies and understanding of the disease pathology, which part of cornea is affected, and that can only be taken care of. So that is what we have come from a full thickness graft to a partial thickness grafts. And the advantage you all understand. Thank you for kind listening.
I think that was an excellent presentation which covered everything and so simply shown, but so difficult to do actually. So all simple things and effortless things are not so easy to do. There's a huge amount of effort which goes in there.
Definitely with the DMAC, one has, with the kind of quality of surgery has improved so much that one feels that one can do the surgery at an earlier stage, like the case that you showed, because we can go for higher outcomes, quicker rehabilitation compared to what traditionally used to. So we can offer the surgery and early vision to patients whom earlier we would have said, you better wait with what you've got. So that's the biggest thing, I feel.
Yeah, you are correct, Radhika. I think now we talk about backlog because initially all these cases we would wait for cornea to decompensate and patient to come back with bullous keratopathy, and the term pseudophakic bullous keratopathy is based on that. Now that it has to be changed to a corneal decompensation or a corneal edema in these cases, which is persisting for some time. Looking into a cases of cataract surgery or cornea doesn't recover in next 3 to 6 months, that is the time you need to do surgery because we don't want corneal stoma to get damaged in these cases because of chronic edema. The recovery also increases in these cases. So we don't talk about now 1000 cornea thickness or so because the cases has to be taken before that. Why should I wait for a cornea to become 640 or so? Why not at 580 itself? Because Indian corneas as well are thinner. So 580 is also a significant edema in these cases. So this is a time where we have to understand not to let patient wait for that long, where patient doesn't become suitable for these modern surgeries. So it is a legal issue in future. If somebody has gone into a bullous keratopathy, that is a sort of, I can say, a negligence on part of our medical health service providers. they could not refer the patient to right place for right surgery in a given time because the pain and the recovery of vision would have been totally different in that group of cases.
So now I invite the next speaker, Professor Radhika Tandon, who's in charge of Unit 6, and she's going to be taking us through another near-life surgery, and that's on ultra-thin DSEC.
Can we have the slides showing on the monitor, please? Thank you. Thank you, Namrata. Thank you, sir. Thank you, everyone, for attending. So I'm going to cover surgical steps for DSEC. Just again, I'd like to highlight that, I mean, the indications and the case selection and all that, all of you know the background, but I would like to re-emphasize that when you actually decide to do the surgery, again, reconsider any special problems that you're expecting in this particular case. So you have to customize your surgical steps for that particular case and take a few minutes to, again, reevaluate the patient on slit lamp on the day of surgery. Look at the status of fellow eye, confirm is the patient systemically fit, again, confirm the consent, because sometimes, very rarely, you may have to convert into a PK or some other procedure. So always remember to take that in the consent and also check if the donor cornea is suitable. So as far as the donor tissue is concerned, as Sir rightly said, we have to be very conscious that we are denying our patients the right to early treatment if we're not giving them adequate cornea. So this is something that we really must step up and make sure the tissues are available, and we have to keep going higher and higher in our quality measures to make sure we're giving suitable tissues. And then once we have the tissue, are we going to get the surgeon to prepare the tissue, or can the eye bank prepare the tissue for the surgeon? This is again different scenarios which may be there in different centers and different parts of the country. Coming to the videos, as far as the donor tissue, again, as I said, verify the source and identification details, because ultimately it is the surgeon's responsibility. Look at the quality assurance, safety screening, serology, etc. And remember that the tissue has maintained its refrigeration. There have been reports of more fungal infections following DSEC, and also particularly following pre-cut tissue, and then it was felt it was because of repeated warming and refrigeration and warming cycles that were undertaken, which could have been responsible. So it's very important that whatever journey that tissue has taken from the donor to the OT is known as in terms of the refrigeration as well as all the other parameters. Now, coming to the donor preparation, you can use a microkeratome. It makes it much more controlled. But there are many surgeons who are very proficient in preparing it themselves without using an automated microkeratome. Talking about ultra-thin TSEC, one would like to get the tissue as thin as possible. One can remove the epithelium so that you can get a deeper cut. This particular microkeratome is a Gabor microkeratome. So in this, you do have a diameter control, that you can control the diameter of the cut. Usually, we would like to adjust it to be 9 millimeters so that you have the adequate tissue to select for your particular patient. This is a 350 micron head which is being used. One would use the IOCT operatively to assess what is the tissue. Thickness of the tissue, and then use the corresponding microkeratome blade. Again, I would like to mention that if one does not have IOCT, it does not matter. One can even use intraoperative pachymetry to decide. And then once the tissue is cut, you replace the cap very carefully, and then mark the edges of the cut part of the cornea. This I will explain later why it's important, because when you're trephining, you want to make sure that you center your trephination in the cut part of the cornea. If you decenter it, you'll have one area which will be full thickness and one area which is the way you want it. So going to the next thing. So here, when you're talking about the so supposing you have now this pre-cut tissue and now you're preparing it for your recipient. So these little dots help you to know that you have to be within that mark. And generally you will like to trephine 3 millimeter less than the white to white of your recipient. So supposing it's an 11 millimeter cornea, you would like to take an maybe 8 or 7.75 donor cut. Once you refine it within it, just confirm that it is full thickness, and then you can store it in a little bit of corneal storage medium. while you're preparing your patient. And make sure that, here again, there are two strategies. Either you can just take the cut donor lenticule onto your Busen glide, or you can actually take the entire cornea and then separate it on with the help of the assistant. And this is how you draw it into the Busen glide. You can put one drop of cohesive dispersive elastic on the endothelial side. Put a little mark so that you know which is the tip of your tissue. So now your tissue is ready. Now, so surgical steps for the posterior lamellar keratoplasty just say that these are variations that you can have. Epithelial debridement and marking will be on the recipient, and then manual dissection you've done, and then the graft insertion. There are various techniques that can be used, followed by air tamponade. So this is for people who haven't been through the cornea unit and are not familiar with the steps. So there are 3 steps. You have the donor tissue, then you prepare the host, and then you inject the graft and you position it in place. So for example, here, if you find, as we discussed earlier, that if all corneas may not be giving you adequate view during surgery, there may be more advanced cases. So if you're having poor visualization, don't hesitate to remove the epithelium. It will improve the visualization of the host anterior chamber. And the other things that you can do is you can use a bright light, you can use higher magnification, and you can also use an endo illuminator to give you a better visualization. As far as cutting of the tissue, you prepare the tissue. Here again, we generally like to have the tissue cut before we block and prepare the patient, because sometimes the things can go wrong and the tissue may get damaged. And then you don't want to be stuck with having removed the host endothelium and not have a donor tissue ready. And this is the way you prepare it for the Busen glide, and then you are going to inject it into the host cornea. Once the donor tissue is inside, with the DSEC, there's not that much of a problem with orientation. As Sir showed with the DMEC, once the graft is inside, then you will put an air bubble to stabilize it in place. So these are the steps in a nutshell. As far as techniques of graft insertion, generally we are using the Busen glide method, but there are various other methods, particularly if people don't, even a Busen glide can be expensive in some centers. The other alternative method is that you put it on a sheath glide and inject it in with a 26 gauge needle and just push it in. And believe me, many surgeons have shown excellent results with that as well. But definitely the Busen glide is a method that we recommend because it is controlled and relatively easy. Now, coming to this patient, as you can see, this is the patient of pseudophakic bullous keratopathy. And a gentle mark is made on the host cornea. This is the same diameter of the trephine that we have used to cut the donor cornea. As Sir said, it doesn't matter if your donor tissue is a little larger than your host cut, but generally we aim to be about the same. A very gentle mark, and you like to have around 1.5 millimeter rim all around. And then you have to select, for each patient, you will have to decide which is the place that you want to make your ports. Often these cases have got some complication. There may be peripheral anterior synechia, the pupil may be irregular, there may be vessels. So all this you may have to customize according to that particular patient. And then we have to make a separate opening for the AC maintainer. 2 things to note. See, now here the AC maintainer is impinging into the area where my donor is going to open. So be careful of that. Sometimes our Indian corneas are of a lesser diameter. So you have to sometimes compromise, but otherwise we would like the AC maintainer to be facing outside. And also the opening of the AC maintainer should be directed, the bevel should be directed towards the angle and not towards the graft, because we don't want it to displace the graft. Regarding the scoring here, at this particular cornea is hazy. So one has used trypan glue to stain the endothelium, and then one is using the reverse Sinski to score the desmids. Following cases of pseudophakic bullous keratopathy, there may be inflammation, because often they may have been complicated surgeries. So unlike Fuchs dystrophy, where it comes out, and even CHED, where it comes off very easily as a sheet, here sometimes it may come piecemeal. The desmids may also be more adherent. And so you must make sure that you've removed all the tags and there aren't any tags. And the different strategies can be used again to visualize. You can put an instrument inside, see it against the contrast, and you can use IOCT to make sure that you have the tissue completely. A little note about this AC maintainer: you can either have it on an IV stand and use the assistant's help to switch the fluid on and off, or you can connect it with the phaco machine and do your own foot switch control of when you want the fluid to be going in and when you want it to be off. These are few variations. And then, so just to go ahead, now we have reached the stage that you want to put in the donor tissue. Before actually loading the donor tissue on the Busen glide, do a dry run, because it's not very easy all the time to make sure that you're coming out comfortably. So you're going to put in the forceps from one side, pull it through from the other side, make sure that it is comfortably going in and you're not losing the chamber too much. Once you're sure about this, also the opening of the forceps, make sure it's vertical and not horizontal, because remember that the tissue that you're going to take is oriented this way. So you want it to grab this way rather than this way. And we do have smooth non-tooth forceps as well. But I personally find that the vitrectomy forceps is better because you don't have a risk of it slipping when it's coming in. So it gives and it's just a pinpoint touch at one end. It doesn't really damage that many endothelial cells. Now the donor tissue is being taken and it's being put. So here, as you can see, the anterior lamella has been taken out. This is another variation. The donor lenticule is now floating in the viscoelastic, and then now it's being picked up with the Busen glide. As you can see, it's very thin, and sometimes it may fold over at this stage and it may get damaged. So that is why I explained. I now prefer to take the entire complex onto the Busen glide and separate the anterior lamella on the Busen glide, because in this step, we don't want to damage the tissue. You can hold the tissue with your forceps and pull it through, and now it's ready. You can either put a little, and personally for DSEC, I don't make any mark as such because it's not, orientation is not an issue, but for a beginner, you can definitely put an S mark on the stromal side. One point here is when inserting the graft, now your AC maintainer is on, your wound is open, that fluid is likely to come out and push your graft back into the Busen glide. So this can be a little bit tricky. So this is why I said I like to use the vitrectomy forceps, because it gets a good grip. Once it's in, it opens up, and then you can pull out the AC maintainer and then inject. You can see, remove the AC maintainer. Once your graft is in, you will take your foot off the foot switch. You don't want the fluid to be going in. So when the graft is in, the fluid inflow is off. And then you put in air. You can select which of the openings you want to use to inject the air bubble. And then if you find that it is a little decentered, you may either use a Reversinsky or even external massage. In this particular case, if you notice, I'd shown you there was a peripheral anterior synechia there. So I knew it's not going to be easy for the graft to move there. So therefore, I used the Reversinsky to manually bring it. So each particular case, you have to modify your technique accordingly. So, of course, the IOCT is extremely helpful to confirm whether the graft is well attached or not. And this will just give you a variation of cut using the Moria microkeratome. The Gabon microkeratome has microkeratome heads at 50 micron, 25 micron gaps, and the Moria has at 50 micron gaps. The Moria cuts a little bit more, and the Gabon a little bit less. But there's no clear guidance on that. This particular one, we're using a 400 micron head, which is, we have had perforations when we've used 400 micron, but this particular case, we were very confident about the thickness, both with the IOCT as well as with the intraoperative pachymetry. So we used 400 micron microkeratome head blade, and we ended up with a graph which is about 70 micron. It's a little bit risky because there can be perforation. So personally, I would say just use 350. If the tissue is a little bit thicker, it doesn't matter. The only problem will be that there may be a little hypermetropic shape. The ultimate thing is to give vision to the patient and make sure that you give a good surgical result. And sometimes it can be very difficult. Surgeries can be very difficult when the cornea is very hazy. But still, I personally feel that provided there's no extensive scarring of the stroma, I feel a DSEC is much better outcome as compared to penetrating keratoplasty. And the post-operative management, supine position. For DSEC, I don't routinely do any PI. It's for DMEC, it's mandatory. You can reassess the patient 1 to 2 hours later. Because we have the luxury of admitting the patient, we are able to reassess and if there's any problem about raised intraocular pressure. But if people are doing a daycare procedure, they send the patient home, then they keep the patient for 2 hours, check on the slit lamp, check the pressure, check the air bubble, and they only then send the patient. The idea is that there should not be a patient having a pupillary block at home and then having to rush to hospital in the middle of the night. Topical treatment, antibiotics, steroids, lubricants and saline, and follow up first day, 3 days, 7 days, explain RSVP, and then every month afterwards. And I'd like to acknowledge all the contributions all of you make to arranging the corneas and taking care of the patients, etc. And the eye bank, of course. Thank you.
Thank you, Professor Radhika. I think wonderfully shown the steps of a DSEC procedure. And she rightly pointed out various ways to prepare the donor corneas, post preparation techniques. As we know that not every part of a country would have a microkeratome for a people to have access to. And with the, I think, adequate learning and experience, you can do a very nice manual dissections also. Only thing you require are artificial disposable chambers for these cases and a few dissector which are quite easily available nowadays to have safe dissection of a donor corneas also. It will be a very rare time where it would require another tissue for as a secondary measure for not having to cancel the patient. And normally DSECs are very, very simple and it can be done in a right way. Only difficult situation come up as Dr. Radhika was talking about. If you have a very, very hazy corneas, lot of peripheral antisynicias, you are not sure what is an anterior chamber, the poor pseudophakic conditions. Sometimes you have a aphakic condition, you may have to exchange the lenses also. And you have to combine various other procedures like fixing the IOL, which may be a scleral fixation or other techniques, AC IOLs. That makes surgery more difficult in a DSEC procedure also. In a simple surgeries, as I told, the surgery can be over in 15 minutes also. But if things go wrong, then it takes 2 hours also sometimes to come back to the last step of these surgeries. As rightly shown, one of the difficult situation was in our time was to understand what is the correct position of lenticule inside the eye. Because selection of cases were very poor in those days. We used to take only those patients where cornea was absolutely hazy. We never, thought of doing a surgery in a clear cornea in those days because we didn't have the expertise for long-term results of our cases. Now we know that we have experience of more than 10, 15 years of doing a DSEC in this center. And the outcomes are very good in all our cases, right from the pediatric patient to adult patients. And on the table, you can understand your graft is correctly oriented, graft is well attached with the help of IOCT. If you don't have IOCT also, give enough time for a air tamponade to be there, along with what we discussed for a high draft cases also. It is basically a bimanual technique of maintaining the intracameral pressure and the external massage, which will take care of interface fluid very effectively in very fast manner. And the graft gets attached very effectively. The only problem for all these patients, like they might have a post-op raise of pressure because of pupillary block. That can also be easily managed in these patients, now with the various other techniques. I think endothelial keratoplasty would be there in a different forms. People talk about PDEC also. That would also be there because it has its own advantages. PDEC would require any sort of a donor. You can do PDEC procedure in terms of donor preparation wise. While for a DMEC, you tend to have a 40 plus donor cornea in these cases. DSEC you can do for any age group. If you're using a manual dissection or a microkeratome dissection, if you have very young tissue, it is very elastic, so you have to be a little more careful at dissecting properly in these cases. Otherwise, the number of cases are going to increase because, as I said, detection, diagnosis of fuchs are increasing every part of the country. If you look in the eastern part of the country, West Bengal, there are surgeons who have reported almost 60% of their cases are fuchs for requiring DMEC. That is the largest in across the world also. So we may have ethnicity differences in the Fuchs dystrophy, but as far as we are concerned, our ratio is around 30, 70 or 40, 60% Fuchs versus PBK requiring a DSEC or a DMEC cases or through our National Eye Bank. Now we have Professor Namrata Sharma shifting to a little anteriorly from the posterior lamellar keratoplasty. And she'll be talking on deep anterior keratoplasty. The results of these surgeries, if done perfectly, is much better than any other surgery because you are hosting the normal endothelial descent complex for patients. And that is the advantage of these cases, apart from taking away the entire diseased tissue. And she'll be taking us through the entire the beautiful surgical tips which she has been showing the entire world for so many years. Professor Namrata Sharma.
Thank you, sir. I would be talking to you about big bubble deep anterior lamellar keratoplasty, and the advantage, sir has said, that you are able to get good visual acuity in these cases, especially if the endothelium and the Descemet's membrane is fine. And it is an important technique for our country or our center because of paucity of good quality donor material. It is a technique to go to, especially in endothelial sparing pathologies. There are no financial or proprietary interests, and there are various techniques which have been talked about, but the gold standard remains the big bubble technique by Anwar et al. Although the other techniques are more doable, the results of the big bubble technique are really spectacular because you reach right up to the level of the Descemet's membrane. The advent of Dua's layer, which sits right on the Descemet's membrane, condensation of stromal keratocytes, has changed the way we do our surgeries, which includes DALC. So if your air bubble goes above Dua's layer, then it's a type 1 big bubble. It looks something like this. Rough surface because part of Dua's is also what you are looking at. And if your big bubble or air goes behind Dua's layer, then you get a smooth surface because obviously your Dua's layer has been stripped off. So sometimes you have fairy tale like big bubble dalks, which doesn't happen always. And this is almost like a fairy tale big bubble dalk, which is obeying your commands. So a partial thickness trephination is done in this case, followed by a big bubble, which is being instilled at a depth of 60 to 70% depth. And as you instill this, the Descemet's membrane falls back. And as you give a neck in the overlying stromal layers, the Descemet membrane starts to march upwards towards the overlying stromal layers as the air egresses out. So you know that you are in the correct place and you have reached the supradescemet's membrane compartment. And then again, with the help of the viscoelastic, this supradescemet's membrane compartment is reinforced so that the descemet's membrane falls back like a kangaroo's pouch. And then the dissection is done of the overlying stromal layers. And you are literally working on the what is said is a viscoelastic corridor or a viscoelastic cushion. And this is the bare Descemet's membrane which is looking at you. And a full thickness donor cornea from which the Descemet's membrane has been removed is then sutured with 10-0 monofilament nylon sutures. So a desmetic DALC has been achieved. Now, sometimes you have a type 2 big bubble which goes from the peripheral to the center. You can see that the big bubble is come right up till here, moved from the periphery towards the center, unlike a type 1 big bubble which moves from the center to the periphery like in the previous case. And you don't allow it to go beyond this keratectomy edge because if you do, then you will not be able to do AC paracentesis. And once you do the AC paracentesis, the Descemet's membrane drops down or falls down. So your subsequent dissections become much simpler. And the air bubble, which was there, because it is a type 2 big bubble, it is tending to expand. Now, always when you give that brave slash or a brave nick that you are giving it, do it with a stained a blade or a stained blade breaker, because you know where you've given it once you need to inject viscoelastic. So again, notice that how after giving putting the viscoelastic, this Descemet's membrane compartment is again reinforced, and you know that you are in the correct plane. Now, this was a case again where a big bubble was being planned, and There is some area of pacification which is here, but this is not a healed hydrops because the Descemet's membrane doesn't look scarred. So partial thickness trephination is done just like you do for all cases. And then a needle is taken, and when you are injecting the needle, the bevel should be down and you come across this needle and come right up to the pupillary edge, and that is your go-to place for injecting big bubbles. And this can also be seen on the intraop OCT microscope. You can see that you are almost quite deep. And as you inject the air bubble, you can actually see the depth at which your needle is by looking at the intraop OCT microscope. So as you go to the area, which I said my go-to place is edge of the pupil, and that is a good uh, landmark where you should be injecting. But this bubble is peripheral, which you can see from the emphysematous area also. So just as you realize that, you dip your hand a little down. So now you have actually obtained a partial bubble, which is present here, but not so present here. And if you look at the edge, you can also see the edge of the Descemet's membrane there. So as you move this in various parts, you can actually make out where the bubble is sitting, and you can make out that the bubble is there. So the Descemet's membrane is seen there, but when you move it towards this side, it is not seen there. So the bubble is only partial. So like a true DALC surgeon, you go ahead with the DALC. As soon as things becomes unclear, the first step is that you make a nick, and then the stromal layer is removed so that your visibility gets a little better. And once that happens, then we are now trying to do a visco bubble. So the bevel is up here loaded with the viscoelastic. De-roof and very quickly inject the visco bubble, because this visco bubble is also going to go to the area where it is attached. So notice how the viscoelastic is coming out, because it has already gone to the area where the Descemet's membrane is detached, and this part of it is the one which is not detached. So be prepared that we will have to do a dissection aided mechanically as well as by viscoelastic when you come to that area. So the area where the visco bubble is already formed and is detached is tackled first, and we remove the overlying stromal layers from that part. And then gently we separate, and we keep separating using the viscoelastic, because now we do have a plane which is there, which is at the level of the Descemet's membrane, which has been defined. And so subsequently, the ledge is also dissected. And this is how you like to see the Descemet's membrane staring at you, and you are still extraocular, and you've not perforated the Descemet's membrane. And then again, you can place a cornea on this. You have to wash away the viscoelastic, because that can get trapped as you place the graft, but be very gentle, because even with a drop of a forceful drop can also cause a tear or a rip in your Descemet's membrane. So very gently wash away all the viscoelastic, and this is the cornea, which is then placed and sutures are applied. Again, taking very care that you don't perforate the Descemet's membrane, because even during the suture, sometimes you can take it through the Descemet's membrane. Now, this is intradescemet's membrane bubble, something which Dr. Tityal sir and we had described way back almost 12 years ago, but this does happen. So again, we are injecting the air bubble, looking at the intraop microscope, almost 90% depth there. And then subsequently, this bubble is obtained. Now, as you do dissection, sometimes it becomes very tricky. You have two bubbles, one sitting above Dua's layer and the other sitting below Dua's layer. And you can see that the Descemet's membrane is fallen back. So when the Descemet's membrane is fallen back, and as you are dissecting, there is a bubble, a larger bubble, which is there in the periphery, and a smaller bubble, which was there inside. And always give a nick. Always stain your nick, because you would want to know where you have to inject the viscoelastic, especially if it's a opening which is small and it gets lost in the stromal layers. And again, the next step would be that with the viscoelastic, especially if you have intraop microscope, it always helps to know that your Descemet's membrane has fallen black. And this is whole Dua's and Descemet's membrane complex, because it is thicker than what it should otherwise be. And this was a case of macular dystrophy. You do tend to get these kind of granules or granularity kind of a picture when you do DALC in cases of macular dystrophy. And then, of course, keep putting viscoelastic. as you even do the dissection of the peripheral part, because if you don't, then you might hit the Descemet's membrane. Keep your scissors absolutely parallel so that you are parallel to the Descemet's membrane and there is no perforation of the Descemet's membrane. And of course, then the graft can be sutured the onto this surface and with 10-0 monofilament nylon sutures. Now again, sometimes when you are dissecting, then there is a big bubble there, which you can see here also that the bubble is there, very much there. But as you give a slash, a brave slash there, we call it brave slash because you shouldn't be hesitant about it. You should give it and the bubble goes plop, and then you can see that it's looking as though it's really come very close to your the Descemet's membrane has come very close to your stromal layer. So just put some viscoelastic there to reinforce this a little bit. And whenever that gets blurry, the area of the incision, you can put viscoelastic because it will get magnified and then you will be able to see that again. So, and then subsequently push your viscoelastic there. And then again, your entire complex will dip down as shown here, and the subsequent dissection can then be undertaken. Now, sometimes when you're doing dissection, especially if you're doing a closed dissection, again, a big bubble has formed in this, the bubble starts to leak and you don't realize it till you do the dissection. So this is the dissection which is being done. The closed dissection, I always feel should not be done in these cases, but sometimes when you do it, while dissection only the air leaks out. And when it leaks out, then again, it can get a little tricky. You may have to push the air again. And as you do AC paracentesis, the area where the air had leaked down has to be again, just notice how you couldn't see the Descemet's membrane there because it had gone so much back that it was sitting on the iris. And as you decrease a little bit of pressure there, then it starts to flutter and you know that from the iris it has now jumped up. So sometimes this can also occur that so much of pressure has been built up that it is sitting on the iris and is not seen on the intraop OCT microscope. Then the dictum remains the same, separate using the viscoelastic, take out the ledge there and then put the graft. Now at times, even while doing this procedure, like I said, you can have perforation as has occurred here and you can also see it there and the aqueous starts to leak out. So go from the other side, leave this side here only. Leave a little bit of ledge there so that it self-seals and it forms a valvular sort of a thing there. Even if you leave a bit of tissue there, it doesn't matter. And then gently tease off the tissue which was left there and you can put a graft on this as well. And this does self-seal in the post-operative period without any problem. So, to conclude, the big bubble DALC is possible in almost all cases of keratoconus. It does have a learning curve, and intraoperative OCT has helped to refine the technique further. Not that you need it all the time, you can do it without it also. We were doing it earlier without it, but this is just to show because it helps me to explain you better as to what is happening when you're doing the various steps. Thank you very much for your kind attention.
Thank you very much, Namrata. It's a very difficult surgery, very beautifully demonstrated, and very rewarding. So it's a surgery that everybody should learn to use because, as mentioned, it has all the benefits that you're retaining the patient's healthy endothelium, plus you're able to optimally use the donor tissue. But do remember that you should have a optical grade tissue backup in case you perforate and you do have to convert. Okay, so we come next to Dr. Professor Tushar Agarwal. He's going to give the video demonstration of SALC and ALTK. Again, very rewarding and useful surgeries.
Thank you, ma'am. Is it on, Mike? So I'll be showing a case of SALC. So as you might be aware, this is more like a LASIK surgery that you apply a microkeratome and remove the diseased host cornea. So it's applicable for conditions where the opacity or the disease is limited to about anterior 200 to 250 microns. And then you do the similar step on a donor cornea and you apply the donor cornea on the host, and you can seal the edges with glue. So I thought I'll show, this was the last case which I have done, and I encountered a problem, and I thought I'll show this because normally the cases go uneventfully. So this was the patient is a 74-year-old male patient, a farmer by occupation, and presented with diminution of vision in both eyes since about 2 years. And the vision was 6 by 60 in the right eye and 6 by 36 in the left eye, and he was pseudophakic. And the diagnosis was ocular surface advanced OSD, and the on OCT the opacity was limited to about 100 microns of the depth. So I planned a SALC with a graft and the donor cut off around 160 microns because that was the most optimum size available to me. So we'll proceed to the video. So this is a similar machine which ma'am, Dr. Radhika showed, but instead of a 400 micron head, it's a 160 micron head. So the problem which the case started was that the donor was about only 8.5 millimeters, and normally can get the controls here to pause. No. Okay. If I just click on it, it'll pause. So the typically when we do these cases, and initially I used to do with them do these cases with the Moria microkeratome, you used to get a very uniform sizing of the host and the donor, the diameter. But in this case, uh, after I applied the microkeratome on the host, I found that the host cut it was able to remove all the pathology as far as in the depth was concerned, but the diameter turned out to be much larger than the donor which I had just cut. So the second part, which I have not indicated in this video, I tried to use a second donor, but the donor cut was of a similar diameter. So now I had a shortfall of the donor. So you can have two problems. Either the donor cut can be larger or it can be smaller. So larger is very easy to handle. You can just measure the host diameter. So for example, your host is say 8.5, you get a donor of 9.5. You can just punch out from the center the donor 8.5, and you can be done with it. You are aiming for a similar size. But what to do when you have a smaller donor and which is much smaller, as we'll just see. So now I was in the situation where I've cut the host, but my donor is much smaller, and I've already used up the backup eye as well. And I can see a large gap which is going to be there on the superior side. So obviously I cannot leave this gap. So what I thought was that since now I have access to the remaining host tissue which has already been cut lamellarly, so I thought I'll just try and retrieve a piece of the cornea which is away from the visual axis and use it as a filler to fill that gap. And in order to achieve that, I put the host cornea back onto the eye, and I put the donor cornea, and this was the deficit left, and I marked the remaining crescent with the Sinsky with the GV paint, and this was the so please remember, this is the host cornea which has been put back, and the donor cornea on top of it, and this is just to get a reference that this is the amount of cornea which I need to get out as a filler. So this is just so now I remove the donor cornea, and now from the host cornea I need to retrieve this small crescent. So I measured the remaining diameter. So this was to get my refined size. The host is still attached slightly because this Gabor microkeratome cuts like a LASIK flap and sometimes leave a hinge on one side. So I'm just reinforcing the mark which I'll need to refine. So I'm trying to retrieve this piece so that I can fill the gap in the created by the smaller donor cornea. So I think the initial thought was to cut with the scissors, but then I just this is me just relieving the hinged element of the host cut. So I didn't. The videos are not edited. It's like a live surgery, live surgery. So it'll have some rough edges. It's not that smoothly edited. So this is the host, the donor cornea, as I said, smaller, and you can see the gap which is left on the top side. So I'm trying to adjust because it might have a slightly oval shape. So my idea is to cover the inferior part as well as I can with the donor cornea, and the exposed part in the palpebral area also, and the superior area I can cover with the host tissue. So I transfer the host tissue. Remember that I have created a crescent on top of it and measured the inner diameter. So this was all thinking on the fly. I mean, I was not just trying to figure out how to best get out of the situation. So I put the trephine on the cornea to get out this trephine. So I just took care that I punched through and through so that I did not have any attached edges. So I'll just take it under the microscope without trying to pull on it. There. So I could get a very nice crescent shaped cornea, which I wanted to fill the gap with. Little bit of gap is acceptable. One can leave, but not. I could not leave such a large uh, gap in the donor. So I just unfurl the crescent. And all of this work is going on a dry cornea because the friction helps to keep it in place. And slowly, but the crescent goes right into the defect which has been left. I think I trimmed, I don't know. So the gap is nicely filled, and then so now the entire, so the area which I wanted clear is being covered with a clear donor cornea of similar depth, 160 microns. And the defect which was left has been covered by a piece from the host cornea itself. And once I reapplied the remaining stromal tissue, then you use fibrin glue. So it comes in two components, fibrin and thrombin. So I typically use them separately. So it gives me a little more time to adjust if things are required. So usually I'll put the thrombin first. So just use a drop of thrombin to paint around the edges. You don't need a very large quantity. And then you use, this is slightly more than normal because I was not sure that whether this piece will take or not. And then you apply the fibrin glue on top of it, wait for 10-15 seconds, and then wash off the excess glue. And then the final step in this surgery is to apply a bandage contact lens. It stays for total of 6 weeks, changed every 2 weeks interval. And that's the end of the surgery. And this was the day one post-op appearance. We found that on OCT and everything on slit lamp examination, the piece which we were more bothered about this area where we had applied the host cornea remaining piece. And subsequently, this was day one follow-up. The patient gained about, I think, 2 or 3 lines of vision after this and remains under follow-up. This is about a month back. Thank you.
I think you made a surgery a little difficult, you know. You're correct. Sometimes manufacturing both host and donor in a right way is very difficult.
Yes, the
Sometimes,
technician was there in the OT,
Yeah.
and we use that applanation. So for those who don't know, there is a applanation type of instrument available. So you can so it gives you the size of the bubble and the desired size of the graft, and you can, as you increase the pressure on the donor cornea, the appellation tonometer type of micrometer tells you, but somehow I just could not get a graft more than 8.5. And the defect, as I showed, was too big to be just left.
Okay.
So that's how I came out of the situation.
I think that video from Radhika did show that appellation
Yes, yes, yes.
lens when she was preparing the,
In fact, I went a little beyond. In my second attempt, I went a little beyond the bubble also, just to make sure.
Sometimes what happens when you actually doing appellation, you get it. When the keratome runs, the pressure is so much, the fluid goes back. You don't get the same amount of tissue rigidity for cutting. So you have to have a clamp in the right place so the fluid doesn't go back with the pressure of keratome. So clamping is also a very important aspect for maintaining the equal pressure of the cornea when the keratome runs. That is very important aspect in keratome handling.
No, but but after this surgery, sir, because this was in SAL, it's a very good odd surgery. I mean, the odds are very good of getting a good outcome. The only problem which I have faced in all of the cases which I have done was this situation. But now I think I found a way that this, because if you have a larger graft, it's not an issue. Same graft you are wanting, about 10%, 10-15% of cases you used to end up with a smaller graft. But now we have found a way to overcome that situation as well.
Now, what about the post-op astigmatism, which will be different than a routine cases where you have a nice fit?
Sir, we'll see, because I have done cases where the fit has not been 100%. Especially I've had to leave some gap, but it doesn't matter. I think the most important determinant is that you leave the BCL for 6 weeks.
Okay.
And if you remove the BCL before 6 weeks, then I found the astigmatism becomes higher.
Thank you very much, Tushar. And one very important message from Dr. Tushar's presentation is always save the host cornea. Don't chuck it away, save it because you may need it. So always keep it carefully. Otherwise, so always be conscious, tell the sister, etc., to keep it saved till you finish the case. So that was a nice demonstration. The other point is that the glue, earlier we used to put it on the bed, and that may in fact add to the astigmatism and add to a bit of a haze. And as Tushar nicely said, it's considered like a LASIK. So the glue, you can just put it around the edges and keep the BCL. We used to earlier with the microkeratome cut 160 and 180 micron LASIK flaps. If you long ago, sir. So from that point of view, if you're around 180 or less, then I think it's fine to put the glue just at the edges. So we go ahead now with the next video demonstration by Dr. Nopur Gupta. It is on penetrating keratoplasty and triple procedure. This again is a very important clinical surgery and very, very relevant today, even today.
Thank you, ma'am. After moving on from complex lamellar corneal surgeries, we move to penetrating keratoplasty, which is full thickness and probably the most common corneal surgery performed in the country. So I would like to spend a few minutes on the patient preparation and counseling in the surgery, which is quite simple as per the surgeon's expertise. But the involvement of the patient and the patient's family with the surgeon is very important in such cases. So we need to understand which patients would be suitable for penetrating keratoplasty, and a proper counseling session with the patients, the family. It's not just a surgeon's will to perform the surgery and the indication, but we need to understand that the routine activities and the vision requirement of the patient before we go on to perform a penetrating keratoplasty. The visual potential is important. Associated ocular and systemic comorbidities have to be taken into account. And we have to consider in high-risk keratoplasties whether keratoplasty is the only surgical option, whether we can rehabilitate the patient visually with optical iridectomy or contact lens trial wherever feasible. And the patient's demographic and socio-economic background is an important criteria because it involves a lifelong follow-up, management of the complications, the lifelong medical management, and accordingly, we have to manage the suture-related complications and discuss the systemic management in cases of high-risk grafts wherever indicated. So going on from the ocular history, etiology is very important in prognosticating the cases. Whichever person undergoes penetrating keratoplasty, the visual acuity, the glaucoma, if present, has to be managed adequately so as to decrease chances of post-PK glaucoma. Management of the lid and adnexa is very important. Before the surgery, they have to be tackled. Any presence of entropion, ectropion, lag of thalamus, and management of the ocular surface disease is very critical for enhancing the visual outcomes after penetrating keratoplasty. The lens status is important because we need to understand that if the patient is phakic, it may need cataract surgery later on, or at this time, like a triple procedure, an IOL exchange may be needed in cases of corneal decompensation, where you have an unstable AC IOL, or a scleral fixation of the IOL may need to be planned with the penetrating keratoplasty or in a phased manner. A detailed fundus evaluation to understand the visual potential. So we may need to do a laser interferometry wherever indicated and a visual evoked response, and assess fixation or any deviation to understand the graft outcomes as well as the functional outcome after the procedure. So preoperatively, very important is that we have to decrease the positive viscous pressure. We have to give mannitol as per the weight of the patient. And usually the penetrating keratoplasties in adults are done under peribarbar anesthesia. The eye should be confirmed. And then this is the whole armamentarium of the surgical instruments that have to be used, which we'll be going through during the surgical video. We could either use a vacuum trephine or a manual trephine for these cases. I would like to fully acknowledge Professor Vanathy for the video. This is a case of macular corneal dystrophy, wherein the proper sizing, the corneal diameters needs to be assessed. This is for two purposes. One is to mark the corneal center for trephination, also to understand how much sizing of the host and donor cornea we need. So as a protocol for a simple case, which is a non-inflamed eye with a stable anterior chamber with no anterior segment abnormalities, we take 0.5 over sizing of the graft, of the donor graft. An RK marker is being used to assist in suture, radial suture placement. Here we are using vacuum-based refine. And one quadrant is actually equivalent to around 62.5 microns. So we are making 8 turns or 2 full turns, which is around 480 microns. And the thickness is a little thinner because in the case of macular dystrophy, which is advanced. So it was 500 microns, so around 90% depth was equivalent to around 480 microns. The first entry is by the MVR knife, and which should be vertical to avoid any ledges. Also note that the Vanna scissors should be sharp, and the blades are kept vertical so as to avoid any ledges in the end. Because if during removal of ledges, we need to be important because they're very critical for post-operative astigmatism and also for graft host apposition. The RK marks which have been left on the host tissue will help in future placement of the cardinal sutures. And this tissue will then be sent for histopathology. cohesive viscoelastic is then put so as to safeguard the anterior chamber structures, and then the donor corneal trephination is done. The centration is maintained, and with the help of the thumb of one hand, we press so as to get a full thickness cut of the donor cornea. And with the other hand, with the globe fixation forceps, we just ensure that the cut is fully conducted. And then we place the donor graft on the graft holder with some viscoelastic, and then place it over the host bed. The 12 o'clock suture is important, is the trickiest, and it's quite difficult to actually put the first suture. Suturing in keratoplasty is very important because it actually predicts the post-operative astigmatism and the graft host apposition. The 6 o'clock suture is also very important because as that is one where the cornea should be bisected in two equal halves after the placement of these two sutures, and a diamond or a rhomboid shaped corneal dimpling is then formed when the 4 cardinal sutures have been placed. They should be equal in size. That actually shows us that the graft placement has been done correctly. Suturing is with 10-0 nylon sutures, and it should be involving around 90% depth of both the host and the donor stroma, just over above the Descemet's membrane. And it has been shown that around 1.3 millimeters length on both sides of the graft host junction should be taken to have minimal post-operative astigmatism and to decrease any chances of inflammation. The sutures are done in 3 throws, 3-1-1 or 2-1-1. And after the placement of the 8 sutures, we should have an airtight wound. Here now Professor Vanity is doing a continuous suturing. So it's a mixture of interrupted as well as continuous suturing. It's an anti-talk mechanism where, this is especially indicated in cases which are non-inflamed eyes. So in cases of corneal dystrophies, it's a good procedure, but where you have inflammation or you're doing, in cases of heel keratitis, this is not an ideal choice because you may need, there may be suture, loose sutures, there would be suture infections. So we may need to remove the sutures midway and replace them if they become loose or they become infected. The 12 o'clock suture may be replaced at the end because that was the first and may not be very radial. So this is the placement of the last suture. And after the positioning of the 8 cardinal sutures, the viscoelastic was removed and all the suturing is done under air bubble. So this is the completion of a surgery. The ends are buried from the donor side, and ideally we need to see that they should be buried enough so that they do not extrude out on the next day, because the graft edema will subside on the next first postoperative day and the suture might rotate. So we have to be careful. So after ensuring that you can also be guided by the intraoperative keratometry to see there is no astigmatism peroperatively. And thank you, sir.
So beautifully done surgery, Vanati. Terrific hands. And in terms of, penetrating keratoplasty in India, this art has to be learned by all of us, because this will never go away from the, in the list of corneal surgeries in next 100 years also. People will have to do a full thickness grafts. And it is much more tougher, much more difficult, and has a huge learning curve to achieve a perfection in this surgery. So you saw this surgery so comfortably done. It's very difficult to really organize every step of penetrating keratoplasty right from the beginning. If your blocks are not good, if you have upthrust, if you have not put a speculum properly, the pressure of speculum onto the globe, and you can have so many complications which can be totally disastrous. But yes, if you understand the surgical steps properly, you prepare the case nicely, the chances of complication decreases. And it's an open surgery, so it has to be as fast as possible and should be done as accurately as possible also in terms of achieving good opposition of a host graft junction, putting a suture in the right titration of their length, depth, and the tightness of sutures is very critical to achieve a good post-op outcome. Beautifully shown surgery, and thank you.
With that, we go to another very important surgical technique, that is the glue application in corneal perforation. Dr. Praful Maharana will be showing the videos.
Good morning, everyone. So I'll be discussing glue application in corneal perforation. So corneal perforation less than 3 mm size or corneal thinning less than 3 mm size, either due to microbial keratitis or any cause like mechanical trauma, chemical injury, rheumatological association, can be managed with glue application. So how to do it? You can do it either the patient sitting at slit lamp or lying down under the microscope in your OR. But remember, this has to be a completely aseptic procedure. So betadine cleaning is a must if you are doing it under slit lamp. Topical anesthesia is the preferred one. So let's begin with a simple case. It was a case of 60-year patient with healing keratitis and desmatocele. This is the glue that is available with us, the cyanoacrylate glue, but you can use any brand that is available in your locality. So aspirate the glue from the vial using a tuberculin syringe and a 26 gauge needle. And if you prefer the needle technique, you can use this directly after cleaning the surface of the defect. So this is an important step. You have to divide the epithelium from all around the area of defect or perforated area, because glue will stick better with that. So take little bit of glue. This is a cap of a ringer lactate bottle I am taking. You can use any sterile plastic drape or gloving or your gloves wrapping paper also. So this is my preferred technique. I take Merosil spear or any instrument and just touch a little bit of glue from the cap and touch it onto the surface. This allows me to apply a very thin layer of glue, because one of the problem with glue is if you apply too much, then there will be a mound formation and that will lead to your displacement of a BCL in the post-op and GPC. So this is my preferred technique. You can use any instrument. People use Sinski hook also. So after application of this glue, you have to wait for a little bit, around 1 minute time. The glue polymerizes, it widens, then it hardens. Once this is done, you can apply bandage contact lens. But this is a simple case, but all cases are not simple. There could be cases where the perforation is big and there is a gaping perforation, or the entry chamber is flat. So this video is from Dr. Sarath. Thank you, Sarath, for letting me present your video here. So it was a difficult case. It was a case of microbial keratitis with a lot of sloughing. The entire chamber was flat and the iris was stuck to the posterior surface of the ulcer. So as you can see here. So in all these cases, first you have to form the chamber either by injecting air. So the important part is first you have to do a paracentesis. Thank you, Sarath, again. So you have to do a paracentesis to form the chamber little bit, and if you are not able to form it with your air, then you can inject little bit viscoelastic for that purpose. This is what is done here. The next step is like previous video. You have to clean all the sloughing material, necrotic material from the surface and debride the epithelium all around that area. But the most difficult part is to form the anterior chamber and separate the iris from the posterior surface of your defect. You can use any blunt instrument like a Sinski hook or even the cannula of your BSS. As you can see here, a Sinski hook was used to release the iris from the back surface of that defect, both from inferiorly as well as superiorly. And this is a very vital step. You cannot let the glue coming in contact with iris, or it will lead to massive reaction and corneoiridic adhesion and posterior synechia. Once this is done, the next step is to apply the glue. And as I was telling you, you can use any backside of any instrument to apply the glue. Here, I think the Sinski hook's back surface was used to apply the glue. Just touch the glue and touch it to the surface. It polymerizes and seals the perforation site. But the next step is, once the glue is has polymerized, you have to form the anterior chamber, which is at times very much challenging. As you can see here, the immediately after injecting the air, you can see the air was not going superiorly. If you see this meniscus, it is here only. Beyond this, the air was not going, so that means some residual adhesion was still there. But don't worry, you can always go back and release it. So as it was done in this case, again an attempt was made to free the iris from the posterior surface. I'm showing this because this is a very vital step. You cannot leave glue in contact with your iris. Once this is done, you can form the anterior chamber. But as I said, such cases may pose you challenge at every step. The moment BSS was injected to form the anterior chamber, you will see there was little bit leak. See, the leak was there, but again, nothing to worry. You can always augment and reinforce the glue with little bit extra application of glue, and most of the time you can successfully complete the procedure with this maneuver. And this Merocil spear you can use to tighten the amount of glue that is applied. Once this is done and you are sure that the iris is free, interchamber is formed, and there is no leak. And here also, if you are not sure whether leak is completely sealed or not, you can use a fluorescent dye to check if there is leak is there or not. Once you are sure, you can put an BCL as the previous I showed you in the first video. So there are other two popular technique. I'll just tell you, this is one technique where you can use a 30 gauge needle to apply the glue. The only problem with using a needle is there is a probability that you may do over application of glue. So to avoid that, what you can do is you form a blob of glue at the tip of the needle and then retract the plunger little bit. The goal is to apply a tiny aliquot of glue onto the surface of the cornea. So as you can see here, the moment I retract the plunger, the size of that blob of glue becomes less. So the goal is to apply a very thin layer of glue onto the surface. The other technique is patch technique. For that, you need a dermatological trephine. You can take multiple circular patches from your sterile drape. As you can see here, there are 4 patches. Take Merocil sphere, apply some ointment to the back surface. This ointment will help you to catch hold of this all the small patches. So with this tip, you can pick one patch. It comes out easily, and apply some cyanoacrylate glue to the patch, and then directly apply this patch onto the surface of the defect. So this technique is supposed to be technically more compared to your glue application, because that extra patch of drape gives you some little bit extra strength. So what next after you have done the glue procedure? You have to continue the antibiotic. Okay, the infection may be still there. Cyclophysic has to be routine in these cases because some sort of iritis is going to happen. So when to remove the BCL, you just leave it on its own. They will slough off and come out, and it may range from few days to 2 months. If it doesn't come out, you can take it out from a slit lamp, using a slit lamp. But remember, before pulling it out, always try to move it little bit. If it is not moving freely, that means epithelialization is not complete. So it's better not to remove that glue. Stay vigilant, because you see, if glue inadvertently you have installed into entire chamber, there will be massive reaction. Either you have to take back the patient to OR, or you have to give steroids. Glaucoma may be there in most of the cases. Why? Because initially earlier there was a free flowing track. Now you have sealed it, so pressure will definitely go high. So keep vigilant about that. Most cases do well. As you can see, these are the few cases where we could achieve complete healing. However, you have to be aware about few complications that the glue can cause. GPC, giant papillary conjunctivitis, can occur because if you see the surface of glue, it's highly irregular. So by some chance, if your BCL is dislodged and the patient is not coming back to you, then there could be constant irritation that will lead to giant papillary conjunctivitis. Stromal vascularization is an inevitable complication of any cyanoacrylate glue application. Why? Because that is the normal reaction of cornea to glue. Infection can occur, especially if the BCL is there beyond 6 weeks. So you have to be aware of this. Lastly, few one slide about whether to go for fibrin glue or cyanoacrylate glue. Remember, cyanoacrylate glue as an office procedure, it is readily available, it is cost effective, its polymerization is much faster. So for office-based procedure or emergency procedure, cyanoacrylate glue is preferred. Fibrin glue, you can do it if you are doing it in OR, and studies have shown both of them gives good result. So I think with this, I'll conclude my talk. Thank you very much for your attention.
Thank you very much, Praful. This is a very useful technique and can make a huge difference in saving the eye. It's something that is important in the armamentarium of the corneal procedures, and you nicely demonstrated the various nuances in its application. So with that, we go ahead now to the ocular surface, moving on from the cornea to ocular surface procedures. And Professor Vanati is going to talk about simple limbal epithelial transplant. This is a procedure which is useful for treatment of limbal stem cell deficiency, and again, a technique which is good for everybody to be aware of and practice. While Vanati is setting up her slides, any comments from anybody else, Dr. Tityal or any other faculty about the cornea session?
Any questions from the house? No, people are sitting here. You have seen surgeries. You have seen initial presentations. Any questions? Or everything is clear to all of you? Because some of the procedures, we have shown a routine procedure, which is would be done by general ophthalmologists also, like a glue application. It is as Professor Radhika rightly said, sometimes you can save the eye, if you're done properly in a time. And if you understand how to do it, you can, very easily help these patients in a difficult times also, especially a COVID time where you don't have a good accessible tissue. Sometimes therapeutic surgery can be difficult. And these glue application has really helped us in many cases.
Sir, in DMEC, why are we preparing the host before the donor? So usually we prepare the donor cornea
No,
before.
this is the standard technique for those situations where you have a prepared donor tissues available for you. If you look in the Western places, normally the eye bank would give you, supply you the pre-prepared donor desmet complex, even stamping also. So you have to directly go with the host preparation. But if you are comfortable for a preparation of a donor, you think that you can do it 100% appropriately, then the host preparation gives you opportunity, as I didn't show that video completely. There's a multiple times your incision can bleed, your iris manipulation can bleed, or sometimes there can a lot of pigment release happening, especially in those cases where you had a history of task type of feature. Then the pigment release is so much, it will hamper attachment. If you give that few minutes of 5 minutes of air tamponade, that will decrease the oozing, that will comfortably take away all the inflammatory things for that particular time. That's why the host should be prepared first. Then you know that how difficult, how easy were your desmet scoring in those cases. Accordingly, then you can think of doing subsequent procedure. As far as we are concerned, because we have a paucity of tissues, we don't have an extra tissue in your hand. It's always better to prepare the donor first. So I know that my donor that roll is prepared nicely, comfortable. Then go for a second step. The only thing at that particular time is that the donor roll should be well prepared. It should not be stained at that time. Just keep it on that preservative medium. When actually you are going to take the donor roll, then stain with the trappan blue for at least 1 minute before you take the roll into your injector. Because the staining for 1 minute is very important, because sometimes the manipulation inside the anterior chamber can take more time, especially if you have to flip the roll, then the entire staining goes off and very difficult to see that this complex in the anterior chamber. So it has to be very fast and accurate. The staining should be appropriate.
So the feature of Gabor that it helps us to decide the diameter of the cut. So is it refining the cut, or like what is that diameter has to do?
Diameter of cut depends on how much the appellation going to happen with the blade. That's why if you can titrate the intraocular pressure, then that gives you that appellation of that amount of cornea while cutting. So that is a pre-adjustment. This apart from the pressure which is there in the artificial chamber in the or in the host cornea, the keratometric value also makes a difference. That these are two important aspects. If you have a steeper K and flatter K with the same intraocular pressure and same corneal diameter, you'll have a different cut size. So both there's a algorithm given for this amount of K and this is pressure, you'll going to get this size. So it's never accurate in the most of the time. So it is always plus minus few millimeters. So that's why it's always better to have some extra tissue with you, especially if you're going to act as a prepared tissue onto the host. Because most of the time, if you are just preparing the host cornea, it is normally to see that how much you're going to cut. To have a same 8 millimeter coming is very difficult. So it will be either 8.25 or it may be a 7.75 sometimes, depending on the curvature and the pressure. Okay, Vanati, sorry we held you. You can take some water. You are nervous, it seems.
No, I'm getting allergic to the auditorium dust.
Excuse me, sir. Sir, cross-linking with rose Bengal dye has been described since long. Does it offer any other advantage compared to riboflavin, and are there any current indications for its use?
Okay, I think where is Mantri? Dr. Rajesh can answer that.
As such, we don't have an experience of that, so I may not be able to tell you exactly how comparable both are. But I mean, it can be tried and it can be done.
Yeah, whatever experience literature it has, it is effective to achieve a cross-linking with the rose Bengal also. But it may not be as effective as the standard, thing which we're using in these cases. Otherwise, it would have been a, conventional way of this thing. So it is effective, but may not be as effective as the standard, the technology which we have been using. You want to ask some question?
Can we have Dr. Vanathi's slides on the screen, please? Thank you.
So simple limbal epithelial cell transplantation. So I'll just give you an overview of how the concept of simple limbal epithelial transplantation came into being. Earlier, we were all doing cultured limbal epithelial transplantation. The limbal epithelial stem cells being obtained either autologous, meaning the fellow eye, or allogenic from a living live related donor or from a cadaveric donor. These cells were then bioengineered in a lab. They were cultivated, and these cultivated limbal epithelial stem cells were then transplanted onto the host surface. So this involved a lot of logistics, a lot of manpower, and trained technical people for bioengineering tissue. So the concept of simple limbal epithelial transplantation was then introduced, in which this whole process of cultivating the donor limbal stem cells is done on the host surface itself. So it does away with the cost and the logistics which are involved. So it's a simpler procedure, but the concept essentially remains the same. So I'll just run you through the salient steps which are involved in a SLET procedure. So the first is a donor epithelial lenticule harvest. As I already told you, it could be autologous or allogenic. So most of the time we still resort to SLET in autologous or single when single eye is affected, or there is a uniocular unilateral limbal stem cell deficiency here, and you have the other eye to give you the donor epithelial stem cells. The second stage is the host bed preparation. What is imperative when you look at the host bed preparation is the host eye should be optimized to the best possible status. Here you are dealing with eyes which have ocular surface problems in terms of limbal stem cell deficiency and in terms of dry eye disease. So the surface has to be optimized to the minimal level possible of inflammation. So should have had preparatory anti-inflammatory therapy. It should have also be on the best possible lubricated level. So topical lubrication therapy should have been on for a considerable period period of time before the surface is probably ready to have a SLED transplant onto it. And third is that you will have to optimize the ocular surface reconstruction procedures, which needs to be subjected before you would want to take a limbal epithelial transplantation. That meaning, if the funuses are not adequate, if there is extensive amount of symblepharons, ankyloblepharons, you will have to reconstruct the ocular surface either by simple amniotic membrane reconstructions, or you will have to combine them with mucous membrane reconstructions so that the surface reconstruction is adequate before you would want to consider a limbal epithelial transplant procedure. So most of the time, SLED is not something which you would jump onto an ocular surface where it probably is indicated, but the surface will need to be optimized before for best outcome and for best results before you do the procedure here. The steps per se, you would run it through a conjunctival peritomy, the superficial keratectomy, achieving hemostasis with minimal cautery, an amniotic membrane overlay, and laying down the donor lenticule pieces on the amniotic membrane overlay and positioning them on the host bed with fibrin glue aided fixation and using fibrin glue in these. So I'll just run over to the surgeries here. So these are near live surgeries, which you would see. So this is a donor lenticule harvest, which is being done on the fellow eye of the patient who needs a SLED procedure here. So it could probably, if the patient is cooperative, you could do it under topical anesthesia, patient looking down. Be careful to go into the clear cornea beyond the limbus for about 2.5 millimeters, two vertical incisions being made on the in the site about 4 millimeters apart here, and the conjunctival side is also being cut here. So what you could see here is you're making a rectangular tissue harvest of the limbal epithelial cells. So the positioning and the site you choose is commonly the superior limbus here, and it's a simple harvest of the limbal epithelial stem cells only here. So once these stem cells are harvested, so after the conjunctival incisions, you can use a simple crescent blade to cut out and remove only the epithelial stem cells. Be sure do not go deeper into the stroma. Going deeper into the stroma will sort of get you more of stromal tissue, and the results in cultivating these pieces once they are cut into will not be successful, and you will also land up with increased scarring of the host limbus if you do a deeper cuts here. So once these pieces are once the pieces is harvested, it is then taken off and put in a sterile bowl with the BSS, and see that the tissue handling is gentle and minimal trauma to the tissue here. So now you're looking at an ocular surface which has been effectively optimized. This is quite a bad limbal stem cell deficiency post-chemical injury or uniocular injury, and you could see that insertion of the speculum is being difficult here. And I'm assessing the fornices to see the adequacy of the fornices here. And once I'm able to retract in, I'm doing a peritomy. So a 360 degrees peritomy has been done here. It's another simple technique which I do follow is after removing the fibrous tissues out here, simple snips in the palpable fissure along the horizontal plane at the 3 and the 9 o'clock helps the conjunctival tissue, the normal conjunctival tissue of the patient to recede back into the fornices, and the deficient layer I then use the amniotic membrane to cover the residual defect which is present. So this minimizes removal of the normal tissue of the patient, however scarred it is present here. This is a laborious process, and you will have to do it carefully and take care that you're not damaging the underlying structures. There you could see the snipe which I'm making horizontally, and that allows more of the patient's conjunctiva to recede into the fornices here, and you get a large amount of the ocular surface, anterior ocular surface, which now needs to be covered with amniotic membrane. Achieving hemostasis, I do use with adrenaline soaked swabs. I use minimal cautery here because you do not want to damage the already fibrosed ocular surface by subjecting it to intensive cautery. So repeated applications will achieve you, as you see, a good amount of hemostasis here. And once the hemostasis is achieved here, minimal superficial keratectomy to remove all the scarred or fibrotic tissue on the ocular surface. Remember, you do not need to do a deep epithelial, deep lamellar keratoplasty or keratectomy in these cases, and try to keep it as minimal as possible for best results of your transplanted limbal epithelial stem cells to take on. So the scarred superficial fibrotic tissue is being removed by simple dissection here, as you could see here. I'll go on to the continuation of the surgery. So the defect now is being closed by an amniotic membrane overlay here. The amniotic membrane is spread over the ocular surface to see the adequate sizing which is required to fit in. This overlay can be fixed onto the surface by using glue and additional sutures, as it's a large area and you would not want the overlay to flip off the surface when during the healing period. So the amniotic membrane is tucked beyond on the undersurface of the peritomy edges here, and also fixated with sutures aided with glue. So now the surface is well covered with an amniotic membrane, and the extra pieces of the tissues are cut off here. Again, achieve your homeostasis, and this is being sutured on to the conjunctival peritomy edges and the deeper ocular surface here. And now the surface is ready for transplanting the harvested limbal stem cells which we have prepared earlier. The lenticule is down, placed on the ocular surface and cut into fine pieces here. You could, from a 2 into 4 millimeter harvest lenticule, you could fashion as much as about 8 to 10 here. Remember, the handling needs to be gentle, has to be cut into minimal pieces, keeping the orientation of anterior posterior as much as possible. Sometimes it is not easy to make out the orientation, but it usually does not affect if you do land up putting it the other way around here. So you fashion it into multiple small pieces and place them equidistantly over the ocular surface, and that would help in finishing the surgery. And once you've done, you will cover it up with you'll fix it up with glue, and then place the amniotic membrane, place the bandage contact lenses over here. And as you would watch the surface in the postoperative period with anti-inflammatory therapies with steroids and antibiotic, you will find these fine pieces of glue actually taking up fine pieces of limbal epithelial stem cells will start flattening, and they will start dividing and growing onto the ocular surface and reconstructing the ocular surface as time goes on. This is one such patient of a pediatric uniocular limbal stem cell deficiency, where the surface has been optimized with the surface reconstructions with amniotic membrane with an autologous LET procedure, and about 6 months later, the surface is now ready to go on for a visual rehabilitation procedure, that is a lamellar transplant. A manual deep anterior lamellar transplant is being done for visual rehabilitation for this particular case. So these are really difficult scenarios where we will have to reconstruct the ocular surface for optimizing their medical management and also being able to give them good visual rehabilitation. These are staged procedures, and you'll have to counsel your patients for the prolonged follow-up and continued treatment which is required in these cases. Thank you.
Thank you very much, Professor Vanathy. That was a very beautiful demonstration of SLET procedure. It's a procedure which is very rewarding and can help patients with particularly post-chemical burn for rehabilitation of the eye. Thank you so much. And with that, we go now to another very interesting and important area of surgery, and that is intacs for keratoconus by Professor Rajesh Sinha.
Thank you, ma'am. Okay. Uh, I'll be talking to you about intracorneal ring segments. These are basically PMS segments of 150-degree arc length. And these are inserted into the corneal stroma intralamellarly at 70% depth in the peripheral part of the cornea so that you can have a shortened arc length. So what happens that the peripheral, you insert it. So as you can see here, the peripheral part of the cornea gets deepened and the central part gets flattened. And that's the basic aim in a case of keratoconus. You want to flatten the central cornea. And I'll just tell you about a little bit about surgical plan that you plan the type. You have different types of segments. You can have symmetric segments you put in pairs, or you can have asymmetric segments of different thickness, and you can have a single segment as well. So if you have a cone, you determine the cone location based on posterior float. And if you have a posterior float, if the cone is more than 50% within the central 3 to 5 millimeter zone, then that is a centered cone. If more than 50% is out of the central 3 to 5 millimeter zone, then it is decentered cone. So if you have a centered cone, it's a sort of a symmetric kind of a thing. Central steepening is there. So you can flatten the central part by putting symmetric segments. But if you have asymmetric, if you have, decentered cone, then you want to flatten more in one area and you want to flatten less in the other area. So that is why you put an asymmetric segment and sometimes a single segment. And as far as incision placement is concerned, I'll just show you an example that you have a refractive error of -4 and sphere and -4 cylinder, 40 degrees. So where will you place the incision through which you will place the segments? So the incision is placed at the axis of positive cylinder. So you convert this -4 cylinder 40 degree to positive cylinder. So it will be +4 at 90 plus 40, that is 130 degrees. So 130 degrees will be the site of incision. So this is the surgical procedure. You mark the center of the cornea because it is all cornea centric. You don't have to think about the visual axis. You have to think about the corneal center. And then this is being done with the help of femtosecond laser. So a suction ring has been placed and this is the applanation cone. And then once the cone is there, then you fire the laser and then you get the desired track for placing the intracorneal ring segment, and this is the radial incision that is there. And once the femtosecond laser has been used, then the first thing that you would like to do is that you would open this radial incision so that you can insert your ring segment from here on this side and here on this side. So first you open the radial incision. You can use any blunt instrument like a Sinskey hook. And once you have done it, then with the help of a glide, this is a bifurcated glide, which is used to open the initial part of the track so that you can insert the ring segment easily. So this is the glide which is being used to open the initial part of the track. And once you have opened the initial part of the track, then you can place the ring segment easily. With the help of a forceps, first you put vertically, I missed that point. You just go vertically first and then along the track, you push it and you keep pushing it. Once it's a little bit inside, then you keep pushing it so that you insert one ring segment. And once you have inserted one ring segment, once you have inserted one ring segment, then you put the other ring segment into the other track. Once you have put both the ring segments, place it in position, and then the radial incision has to be closed with a single suture with 10-0 monofilament nylon so that this remains closed and there is no extrusion of there's no movement of the ring segment, there's no extrusion through this. That is what you do. This was done with the help of a femtosecond laser, but if you don't have a femtosecond laser, you can still do it. Again, you mark the center of the cornea, and then with the help of the track marker, you mark the track. And then with the help of a diamond blade or any guarded blade, wherein you have a preset depth, you make an incision. that is of 70% of the area where you are in making the incision. And then with the help of this separator or a dissector, this is used to separate the lamellae on one side while going through that incision, and then on the other side. So mechanically also you can separate and create a track, and then you can place the intracorneal ring segment. This is the intact forceps, which is held, and the forceps, this ring segment is held with the forceps, and then it is introduced. Now, the same way you close it with a suture. Now, you can, in many of these cases of keratoconus, you would also like to, the idea of doing I'll just skip this part and move forward. The idea of doing this ring segment is to regularize the corneal surface. And once you regularize it, then you stiffen it with the help of corneal crosslinking. That's the idea in a case of keratoconus or in a post-classic ectasia. So once you have put the two ring segments, then what you do, you debride the central epithelium within the two segments. And then you put riboflavin, and you can do accelerated cross-linking. We normally do use 9 milliwatt per centimeter square for 10 minutes. That is the protocol that is closest to the conventional Dresden protocol. The outcomes are closest to that. And then you do cross-linking. This is how it looks like, the two segments in position. Now, sometimes you have a very asymmetric cone, very decentered cone like this. In such a case, you may like to put a single segment. Again, you can see the axis of this minus cylinder is 50 degrees. So you add, you make it plus, add 90 degrees, so 90, so it will be 140. So the axis will be at 140. And then you can put a single segment in such a case. This is how it looks like. The incision placed here, this is the single segment that it is. So these ring segments are quite effective in regularizing the corneal topography. And many of these cases wherein they can't wear contact lens, they don't want contact lens, in such a case, you can reduce the astigmatism by using ring segment. Like in one case, the patient had a 10 diopter of astigmatism with 6 diopter of sphere. So first, I put a single segment of intracorneal intacs, and then the astigmatism reduced down to 6. And then a toric ICL was implanted. So still the patient had a residual cylinder of, I think, 0.75, but the patient was 6'9", unaided, and he was very happy. So these are ways to regularize the corneal surface. And ring segment can be combined with cross-linking as well to stiffen the cornea so as to have a persistent, regular, nearly regular, I would say, corneal surface in case of keratoconus. Thank you.
Thank you, Rajesh, for highlighting the important surgical way to stabilize or correct the keratoconus in some way in a cornea which has more than 400 corneal thickness. With there, you don't want to jump for other surgeries because cornea is reasonably good thickness, 400 microns. And as rightly said, these are cases which may be all right with your other optical ways to correction. Maybe contact lenses, rigid contact lenses. But if they are intolerant and you want to regularize the corneal toricity, yes, this is a very good surgical, intervention for these patients. The only thing which is going to harass is cost of for these segments of the patients. But these patients are so deprived of a good quality vision. They accept this also despite having a high cost because this will definitely improves the quality in these cases. After doing an intact, sometimes you can do a re-contact lens fitting these patients, which becomes simpler. And as Rajesh talked about, you can do a faking intraocular lenses to correct the other refractive error in these cases. If you pick up early cases of keratoconus, sometimes you can correct also. Like I've had a patient where they were fully corrected with the intact segments also. But this has a value. But long-term results are sometimes cannot be titrated well in these cases because the cornea may still progress, thinning may still occur. And sometimes these intact segments, they have their own problems, extrusion, intrusion, melting. Sometimes the whitish deposition occurring across the tunnel of intact segments. But most patients do very well in these segments. Thank you, Rajesh, for
Yes.
highlighting all the important
Thank you, sir.
points. Now we invite Dr. Manpreet Kaur. She's going to take us through the, I think, one of the most, I think, appropriate topic of the day for the people sitting here, because all of you are going to do a pterygium surgery. And it has to be done in a right way to achieve a good results on the table for those cases and prevent the recurrence happening in these cases. Because recurrence is one area in pterygium surgery which is a very, very challenging to take care of that. Yeah, Dr. Manpreet.
A very good morning to all of you. So I'll be discussing a case of pterygium excision with conjunctival autograft. So this was a 53-year-old male who presented with a progressive ingrowth over the eye since the last 2-3 years. So we planned a pterygium excision. So the first step is to mark the limbal extent of the excision, and then you can gently score the corneal aspect, just the margins. And then we inject xyloadri solutions subconjunctively at the limbus. It serves two purposes. If the patient is in topical, it provides analgesia and also helps you to dissect the subconjunctival plane easily and to find the plane wherein you separate the pterygium head from the corneal surface. So here I have used a iris repositor to separate it from the limbus to the cornea. I'm moving from the limbus to the cornea after identifying the plane, and the purpose is to just separate the head of the pterygium from the corneal surface. There are two methods to go about it. What has also been described is that you go from the corneal aspect and just peel off the pterygium from the corneal aspect. So this is the second method in which you can gently peel off. Just that limbal clearing with a crescent knife is required more in this method. And once you have separated of the pterygium from the corneal surface, you have to cut at the pre-marked area at the limbus, and you don't go too posteriorly while cutting. That is the purpose of marking with the gentian violet the limbal extent before starting the surgery. So after this, what is important is that you have to clear from the two aspects, the limbal horns that are present at both sides after you have removed the pterygium head, and the subconjunctival fibrous tissue has to be removed. It has to be dissected from the overlying conjunctiva and carefully removed, because this is what is going to cause recurrence and prevent the smooth attachment of the graft as well. So once it's free, you can see the conjunctiva has retracted and there is a scleral bed that is seen in which you cauterize judiciously. I don't think there's a need to cauterize too much because heme in itself helps in adherence of the conjunctival autograft. So IOCT can be a useful tool if you have to see the extent. Mainly in recurrent pterygiums, you don't want to go too deep. And then a crescent knife assisted smoothing of the corneal surface can be done. Superficial smoothing only, you don't have to go too deep. And diamond burr is another useful tool if you have to help smoothen the corneal surface. Not necessary, but as you can see now we have a clear enough cornea, and we also did an IOCT to see that it's a smooth surface after this. And now the important step is harvesting a conjunctival autograft. So you measure the defect, the vertical and the horizontal aspect. So this was a 7.5 into 3.5 millimeter defect. So from you harvest typically from the superior aspect, and you take 0.5 oversized conjunctival graft and you can mark with the gentian violet. It's slightly broader in the posterior aspect, not exactly rectangular. And then again, you inject subconjunctival xyloadri solution to help find the plane. You do not want the tenon in the graft, you just want the superficial conjunctiva. And so you make an initial nick with vanas and then you gently dissect. So your target here is to avoid any buttonholes, to take as conjunctival a graft as possible. You do not want the tenons tissue and any fibrous tissue along with the graft, and you do not want to tear off the graft while dissecting, so be gentle. And go from one side to the other side, and then you can harvest the conjunctival graft. So I leave the limbal aspect till the last, and you evert, and then you can see there is some tenons that is still adhered to the graft that can be carefully removed, because otherwise it will not help the graft spread evenly. So as I said, avoid buttonholes, remove tenons, and cut the graft flush with the limbus. So here I am trying to remove the remnant tenons and subconjunctival tissue carefully without creating a buttonhole. So the purpose is that the graft should spread evenly on the corneal surface at this point. So now it's spreading. You don't have to remove all the tenons at the expense of tearing the graft. Now I'm just cutting it flush with the limbus, with the vanas itself. And after this graft is rotated on the cornea only to the site of the where I intend to place the graft. So limbus is opposed with the limbus, and you maintain the orientation of the graft. After that, you just dry both the surfaces, and fibrin glue is applied. So two components are present. So you apply fibrin to one part and the thrombin component to the second part. And then you just gently hold the graft with the forceps and place it over the bed. Just evert it, because right now it's stromal side up and then it will be epithelium side up. So first aspect is you have to take care of the limbal aspect. Second is the sides, and third is the posterior aspect of the graft. So just quickly spread it before the glue kicks into action, and you just have to oppose the limbal aspects initially. After that, the sides can be trimmed. You can use a limbs or whichever forceps you are comfortable with. So I realized during surgery that limbs was more useful than the blunt forceps had taken. So I shifted to limbs. So sides after the limbus, and then posterior aspect comes last. And any extra fibrin glue, because typically some will come out from the edges, just trim it with a vana scissor, because otherwise the whole graft will get dislodged if you leave any fibrin glue. Thank you for your kind attention.
Thank you, Manpreet, for showing the pterygium surgery, the primary pterygium surgery, because recurrent pterygium surgery can be much challenging sometimes. And as I said in the beginning, it is our job to make sure that it doesn't recur again in your case. Younger the patient, you have more chances of recurrence. And more is the manipulation you do, that means it has a more fibrosis. That means the patient will have a persisting inflammation and chances of recurrence is higher. People do put sutures also to attach this limbal graft. The results are almost similar, except for a discomfort which patient can have with the suture sometimes. Otherwise, the outcome will be almost similar in these cases. Most importantly, you have to avoid graft getting dislodged in the post-op period. So that is a very important aspect. Sometimes you can have a hemorrhages just underneath the graft. That can also jeopardize the graft sometimes. Effectively, people have used patient's own blood, and that can also do a similar outcome as you use for a fibrin glue. That will decrease the cost to the patient, because glues are a little costlier for a single patient. If you can have a multiple patient, yes, 2 or 3 patient can be handled in this group of patients. But two important things he highlighted. One is carefully making the corneal surface smooth. And above that, the limbal area should be absolutely clean. The corneal and the scleral junction should not have any, tags. That is the one area it has to be made absolutely smooth. The white blue junction should be absolutely clear for you. Second important thing you have to realize is removing as far as possible the fibrous membrane or fibrous tissue underneath this. And to remove that, you have to be very careful. Sometimes it can be very bulky also. People have damaged recti also in that situation. So that should be avoided. Remove as much as possible, and remove only those which you think is critical for making that area clean. Three things are important: corneal surface, the limbal area, and the removal of entire the fibrotic tissue, which is so important for these cases. Nowadays, we are not worried like which part of pterygium you're handling. In all days, when we are a student like you, there was a dictum: you could never touch the head of a pterygium. Everything had to be dissected in such a manner. The head is just peeled off in the end of a surgery of dissection of that area, because there's a concept that there is some factor which is actually causing the pterygium to grow onto the cornea. There's some sort of uncontrolled growth factor which was named the P factor at that time. And if there's a release during your surgery, the recurrence will happen. I think it's not true. It is the actual way of surgery which is important for these cases, and decreasing the inflammation. And use of mitomycin and other things, those are left for recurrent cases, not for primary cases. Thank you, Manpreet, for highlighting all the points. Now we have Dr. Soni, and she's our senior resident with us in cornea and refractive surgery. And I think they are the one who look for a cosmesis, and she's the right person to talk about tattooing the ugly looking corneal opacities. Dr. Soni.
Thank you, sir. Thank you, Chief Sir and faculty, for giving me this opportunity. I will be talking about corneal tattooing, also known as keratopigmentation. So to start with, we have to know what is the purpose of keratopigmentation and what are the methods that has been described for this technique. So to start with, it is performed in selective cases for aesthetic purpose, that is, those who cannot use cosmetic contact lenses, or for functional purposes, just to improve the visual quality in patients with iris defects and albinism. So there are two commonly described methods used predominantly. One is the chemical method, in which metallic salts react with each other to produce a brown-black precipitate. This brown-black precipitate is taken up by the keratocytes, thus staining the cornea. The various chemicals used in this technique are gold chloride, platinum chloride, silver nitrate. These three metallic salts are further reduced by hydrazine hydrate 2% to achieve a brownish black precipitate. The other method is the coloring method, in which there is direct introduction or impregnation of colored pigments into the corneal stroma, and the various dyes used are Indian ink, organic colors, animal uveal pigment, Chinese ink, or soot. This is the first case. This was a 24-year-old male who had presented to us with this disfiguring corneal scar, which he had developed at 3 years of age due to microbial keratitis. Thus, he had developed dense amblyopia in this eye, and because it is a full thickness corneal scar, just to give cosmesis to this patient, we went ahead with the chemical method of corneal tattooing. So after proper counseling and adequate consent was taken that this is being done just to provide cosmesis to him, and giving peribulbar anesthesia, we proceed with the surgery. I would like to thank Professor Tushar Agarwal for this video. At first, 20% ethanol is applied for 20 seconds onto the area which we choose to debride, following which the epithelial debridement is done. You can see few areas of spheroidal degeneration as well, which has been taken care of by gentle peeling. After that, the corneal surface is adequately dried before we proceed with the application of gold chloride 2%. Here Here I would like to highlight a few points. That is, the corneal surface should be dry. The second point, to avoid the spillage of the chemicals, at least 2 Merosol sponges should be kept to avoid spillage onto the conjunctiva. And because there are two salts that we use, one is the 2% gold chloride and another one is the 2% hydrazine hydrate. So two separate iris repositors should be used for application of the two separate dyes. 2% gold chloride is being applied onto the denuded corneal surface and is evenly spread. This gold chloride is left for around 1 minute. After that, 2% hydrogen hydrate is applied and is spread evenly onto the surface. So this is the first layer of mixture that has been obtained, and we can see a thin layer of black precipitate that has been obtained on the corneal surface. Following which, the surface is again dried and we apply 2% gold chloride and again 2% hydrogen hydrate. And by doing by drying the surface and by applying the two salts simultaneously, we achieve at least 3 or 4 or 5 layers of this thick blackish, brownish black precipitate onto the corneal surface. Following which, the excessive dye is washed off and BCL was applied. This is the post-op day 1 clinical photograph of the patient of the left eye. Post-operatively, we give prophylactic antibiotic, steroids, and lubricant eye drops, which has to be continued for 2 weeks, following which the BCL has to be removed after 1 week once the epithelialization is complete. This is the second case. This was a 16-year-old young lady who had presented to us with resolved endophthalmitis and retinal detachment on ultrasound. Just to give cosmesis to this patient, we had planned for intrastromal pocket creation, followed by which introduction of colored pigments into the intrastromal pocket. As you can see in the slit photograph, the cornea is absolutely clear. Although she has a component of healed keratitis in the nasal part of the cornea, and she has a dense pupillary membrane, which is shown on the slit photograph. I would like to acknowledge Professor Rajesh Sena for this video. At first, a 50% depth incision is created using a blade breaker, and the initial stromal pocket creation is initiated using a crescent blade. This stromal pocket is further dissected using a lamellar dissector. Here I would like to highlight that the dissection should be 360° till the limbus so that we can achieve a uniform black pigment all around the cornea 360°. Following the intrastromal pocket creation, India ink black dye is used to impregnate into the corneal stroma. Few drops is injected, and using the cannula, the dye is spread into the intrastromal pocket. A component of healed keratitis was also present in this patient in the nasal part of the cornea, so we debride the epithelium mechanically and paint the anterior stroma using India ink black dye. We leave the corneal surface to dry for 1 to 2 minutes, followed by which a BCL is applied onto the surface. This is the post-operative clinical photograph day 1, the above picture, and the below picture is day 7. Post-operative medications would remain the same. A little bit about the India ink black dye. It is a suspension of carbon black particles in a medium such as ethylene glycol. It is commonly available in any stationery shop, which is used in pens for writing and drawing. It is also used in our microbiology lab to demonstrate cell capsules through microscopic examination to detect presence of encapsulated species known as negative staining of the Cryptococcus neoformans. And before injecting into the eye, it is autoclaved at 121 degrees Celsius for 15 minutes before intrastromal use. Thank you.
Thank you, Soni. Both the videos were wonderful. Just one query for our audience sitting here. From where we get these, gold chloride and India ink? For a,
So the India ink dye, we get it from the microbiology lab,
no, no.
or else we can.
Is it available commercially? Because,
It is available commercially in the stationery shop.
okay. And gold chloride?
The gold chloride is available from the ocular pharmacology. 2% gold chloride and 2% hydrazine hydrate.
So the India ink has to be sterilized.
Yes.
Because you're putting
People have to
We have to sterilize.
request for this,
The India ink dye that is provided in our OT that we get from the main microbiology lab.
Another thing I may have missed, but when would you want to do intrastromal and not on the surface?
Ma'am, when the opacity is at a deeper stromal level, or the opacity
Even
is
if you cover it on the surface, won't it get covered?
Same thing.
I'm just asking.
the
It will be the
intrastromal
same
pocket creation, the cases have to be selected specifically in which the
That's what I want to know. Why would you? I think Rajesh can answer that. Why
The-
would you want to make an intrastromal pocket in some cases and not put it on the
the
surface?
dye retention time is more
Yeah,
on the
because
intrastromal.
many times when you do it on the surface, what we have noticed is that after some time, the
Fades away.
dye fades away. You get a tigroid kind of an appearance, and it completely spoils the cosmesis. If you do intrastromal, it stays for very very long, and the cosmesis is maintained.
Yeah. I think the second case where you said cornea was clear, and it was the retrocorneal membrane or a pupillary membrane which was
dissolved end of the
giving the very poor cosmesis. In that patient, you could have customized the lenticule, intrastromal lenticule would have given a beautiful this thing, colored lenticule inside with a darker in the center 2 millimeter and little less dark in the periphery, and that would have been a wonderful idea.
So actually, half of it was having an opacity which was full
Okay.
The
thickness.
nasal part of the cornea had a component of
Because whatever you're doing, it is a may not be as cosmetic as you are thinking, for our people. And same thing could have been achieved by the contact lens also.
Cosmetic.
Because contact lens also, like the type of contact lens we give is a uniformly darker contact lens. But customized contact lenses are also available, which are the pupil optic contact lenses. The same thing could have been. I was thinking if that cornea is clear.
For second case, sir, contact lens is a very good option.
Yeah.
For second case, we can use contact lens because the surface was not very irregular also. Scarring was there, but it was not that irregular that the fitting will be difficult. So in second case, we can definitely use this. I mean, another option, very good option was a cosmetic contact lens.
Okay. Thank you, Soni.
Thank you, sir.
Because these are things which are should be learned by everybody. That's small things, but difficult to get the technical this thing.
And require a lot of patience to do when you know you're only doing only for cosmesis. Then you're.
I think Dr. Parful wants to add something there.
You should emphasize why you were keeping those two mirrocell spheres as barriers.
Yeah,
as members.
I think.
So you have to use that, or else your conjunctiva gets stained. All the purpose of cosmesis is gone next post of day, because the conjunctiva can also get stained by the tattoo.
Okay, I think apart from these opacities, people are doing, all these uh, dye injection into a cornea for, dermoid excisions, where you have a little whitish fibrous thing coming up. All these tattooing things are not only for ungainly opacity, for other procedure also it is very helpful as such. Especially I've seen Tushar doing for all these limbal dermoid cases. It's very effective to do. Yes, okay, we can go to the next session now. I think we are right on time. I request Dr. Namrata to continue as a chairperson there and invite two other senior people, Dr. Vanati and Dr. Tushar, to come up and take the dice.
Thank you, sir. I think we commence with a very important session now, which is on microbial keratitis. And I would request Dr. Amog to present his talk on management of a case of recalcitrant fungal keratitis.
Good afternoon, everyone. Today I will be talking on managing recalcitrant fungal keratitis. Before going into case vignettes on multiple fungal keratitis, I would like to briefly touch upon the antifungal agents. And we have different groups of antifungal agents, namely polyenes, azoles, as well as echinocandins. Commonly in polyenes, we use amphotericin B, especially for candida, in the percentage of 0.05 to 0.3%, and natamycin, which is again commonly used in the percentage of 5%, and azoles, which are commonly used as systemic medications. We have fluconazole, ketoconazole, as well as voriconazole. And echinocandins we use rarely in cases of refractory cases. And we have caspofungin as well as micafungin. Now going on to case vignette 1, where we encountered a 42-year-old male who was a known case of diabetes mellitus, and he brought to us with a history of trauma. Matter, three clinical pictures, including a cobalt blue picture, which shows a dry looking raised texture with feathery margins, which is clinically suggestive of a fungal keratitis, where we went ahead with, as usual, with all the fungal, in all the infective keratitis, we go ahead with scraping, and on scraping and 10% KOH mount, we found filamentous hyphae, which were acute angled, as well as where it showed hyphae, and then on Sabarod's dextrose it showed yellow-green colonies. And in the amalgamation of all these things, it suggests that it was an aspergillus infection. And then on a 2 weeks follow-up of the same patient, we started on topical natamycin 5%. Initially, it was started 1 hourly for 3 days till the clinical improvement. Then it was tapered off to 2 hourly for 1 week. And also he was started on tablet ketoconazole, because as you know, the systemic medications are started for large ulcers, especially more than 5 mm, as well as deep ulcers involving more than 50% of stroma. So both the medications were started, and you can see in the 2 weeks follow-up, the ulcer has started to reduce on size, as well as the epithelial defect has also started to reduce. The same patient on 4 weeks follow-up, after the beginning of the treatment, you can see the scar has formed and the epithelium has healed completely. And this patient got away with topical medications as well as systemic medications involving the antifungals. Now let's move on to the case vignette 2, where we encountered a 52-year-old female patient outside diagnosed to be having a fungal keratitis, and he was referred to us for poorly responding to topical therapy. We found that she was initially put on natamycin outside for around 2 to 3 weeks with poor response. We can also see there is hypopion, and we planned a targeted antifungal therapy involving a intrastromal voriconazole in the dose of 50 microgram per 0.1 ml. And after that, you can see the 12th day follow-up, the ulcer has healed significantly, and the scarring has begun with vascularization. So this was a case of intrastromal therapy, and this was followed based on the TST protocol, which involves topical, systemic, as well as targeted therapy, where we begin initially with the topical natamycin, and then we add topical voriconazole 1% if the response is poor. And then, if especially in cases of deep ulcers and involving anterior chambers, we can try intrastromal as well as intracameral injections. Usually around 3 to 4 injections can be given at an interval of 72 hours. And the final retort, if there is a poor response, would be therapeutic keratoplasty. So this is a case vignette 3. Here a young patient came with a pigmented ulcer. Here we can see with hypopion, and it again clinically suggestive of a demeticious fungi, and microscopy suggested the same thing. And the treatment was started with topical natamycin 5%. But to enhance the treatment, which we did a superficial keratectomy. We took the patient to the OT, and then we did the superficial keratectomy using 50 number blade. And after superficial keratectomy, we again continued the topical natamycin 5%, where it increased the penetration of the drug. And you can see in the post-op 10th day follow-up, the ulcer has healed completely, and the epithelial defect has also healed, and the scarring has begun in such case. Now we move on to case vignette 4, where an agricultural laborer came with a severe fungal keratitis. You can see the keratitis involving almost whole cornea with extensive exudates in the AC, and he was not responding to any topical medications as well as systemic medications. Here we should plan an early therapeutic penetrating keratoplasties to save the eye. And this is the post-op picture showing the therapeutic keratoplasty, where you can see there is a large graft, almost 12 mm, and then the sutures are well placed with near normal angle anatomy. And this is the last case vignette which I would like to show. This was a 34-year-old male patient diagnosed with fungal keratitis being treated with topical therapy. Here we augmented the topical therapy with a PAC CXL, which is photochrome activated keratitis for fungal keratitis, where this is an adjuvant therapy for fungal keratitis, which has been proven in a systemic, this was a systematic review and meta-analysis, which showed around 73.5% of complete healing rate in cases of PAC CXL in fungal keratitis. PAC CXL can also be used in bacterial keratitis as well as acanthamoeba keratitis. The thing to note here is PAC CXL is avoided in viral keratitis because it can reactivate the viral keratitis. So to sum up about recalcitrant fungal keratitis, one thing to note is for all the infective keratitis, we should not start any empirical antifungal before the KOH mount. So first is scraping and KOH mount, and once it is microbiologically provable fungal, then you start natamycin, topical natamycin 5% 1 hourly, and then if there is a poor response with natamycin 5% 1 hourly, then we have to go in with voriconazole 1% 1 hourly. Then if there is poor response to both, and if you feel the ulcer is deep or there is extensive AC involvement, then we have to go in for targeted therapy, which is intrastromal or intracameral. And you have to also see if there is a candida involvement, then you have to start amphotericin B in a concentration of 0.15%. And we have to also know the indications of systemic antifungals, wherein we begin systemic antifungals in the, for example, voriconazole 200 mg BD or ketoconazole 200 mg BD. Voriconazole is better than ketoconazole, but it's a little bit costlier. And if the ulcer size is more than 5 mm, the depth is more than 50%, perforated ulcers, and you have to also remember in perforated ulcers, we cannot do intrastromal or intracameral, and also associated with scleritis and endophthalmitis, we do use systemic antifungals along with the topical medications. Thank you. I would like to thank Chief Sir as well as Professor Namrata ma'am for giving me this opportunity to present.
Thank you, Amog. I think we need to acknowledge Dr. Tityal sir for the TST protocol, which came up because we were giving intracameral and intrastromal, and he suggested that wherein in your decision tree would intrastromal, intracameral come in. And so that was the time when we made it. I think this TST protocol still is evolving because there is another way of treating microbial keratitis, which has come up, and that is the PACT CXL. And that again, has to fit into as of now, we are doing, whenever it doesn't respond to our medications, but somewhere we have to, put it as to when or where we should start using it. I think one important aspect which needs to be highlighted is that when you're doing therapeutic keratoplasty for fungal corneal ulcers, you would start post-operatively systemic antifungal agents. You would start topical antifungal agents, but you would defer topical steroids for at least a couple of weeks because of the fact that the chances of recurrence may be there, or you would defer till the time epithelialization occurs. And when that happens, then you can start topical steroids even in those cases. Anybody would want to ask anything or any comments from anyone? So how many of you actually have done PAC CXL for microbial keratitis? So it's one territory which is not charted PAC CXL microbial keratitis.
This question, there was a question from Dr. Anirudh earlier on using a rose bengal for a cross-linking. If you look into an infectious keratitis point of view, because that may be another alternative to use in these cases, because Rose Bengal photosensitization doesn't go very deep. So it is around 100, 120 or 150 max. So that can be one area for a use of Rose Bengal in infectious keratitis, because this particular use of Rose Bengal may not cause too much of corneal tissue damage because it doesn't penetrate deeper. So maybe that's the one area people might look into a use for Rose Bengal. I thought I'll just add into this area.
So I think again, Rose Bengal is being studied by Dr. Mesqua's group from Miami, and they have published the results of the same, giving the similar logic. We have a PhD student who's doing PhD, and she's also looking into various cross-linking agents, specifically for microbial keratitis, and also the UV radiation which can be given, because whatever has been described for cross-linking is for keratoconic corneas. It's not for corneas which are already where infection has already occurred, and probably the parameters which are required for an inflamed cornea or for an infected cornea are going to be different from the parameters of a virgin keratoconic cornea, where we are using accelerated or resident protocol. And I think it's an overkill for microbial keratitis. You possibly need
That's actually true.
a
Because
different.
you have infectious keratitis happening after, a cross-linking in a normal healthy corneas. What I'm not sure how effective these are, but I think you're right. We have to look into other ways to cross-link cornea in a different ways, where it doesn't damage the cornea that much, where already inflamed tissue there. Okay, good one.
So with this, I think we come to the next topic, and that is again a very difficult topic. Managing of case of necrotizing viral keratitis, to be presented by Dr. Tanveer Alam, who's senior resident in Unit 6. To be discussed by Dr. Nupur Gupta.
Good afternoon, everyone. I'll be presenting management of a case of necrotizing viral keratitis. So, a 62-year-old male presented to RPC emergency with complaints of pain, redness, watering, and diminution of vision in the right eye for 1 week. There were history of recurrent episodes of pain, redness, and watering in both eyes, several episodes. There was no history of ocular trauma or use of contact lenses. He was a shopkeeper by profession, and he had history of diabetes mellitus for the last 10 years. On examination, he had a visual acuity of PL positive with PR accurate in the right eye and 636 in the left eye. And IOP was digitally low in the right eye. Intraocular pressure was digitally low in the right eye and normal in the left eye. And there was mild eyelid edema, a watery discharge, and a diffuse congestion present in the right eye. On slit lamp examination, right eye revealed an infective keratitis with a small central perforation, which is indicated here by a white arrow. Corneal scarring indicated by black arrows, vascularization, and diffuse blood staining, probably resulting from prior vascularization, and an early pseudocornea formation, which can be seen here, indicated by the green arrow. This is the right eye. In the left eye, on slit lamp examination, he had a nebulomacular corneal opacity, indicated with black arrows, and keratic precipitates, and also pigments on the anterior lens capsule. Corneal sensations were diminished in this eye. Sclera was normal in both the eyes. Anterior chamber was extremely shallow in the right eye, and there was iridocorneal touch present at the site of corneal perforation. On ultrasound examination, the eye was anechoic. So coming to investigations, a routine systemic workup including blood pressure, FBS, CBC, LFT, and KFT were normal. Corneal scrapings were done carefully from the ulcer margins. Gram stain and KOH mount were negative. And TF film specimen was also sent for herpes simplex virus, DNA PCR. So based on a typical history, characteristic examination findings, and the relevant investigations, following diagnosis was made: right eye necrotizing stromal viral keratitis and left eye healed viral keratouveitis. Medical management was started. Oral medications, topical acyclovir in full dose, 400 mg 5 times a day was started, along with oral pantoprazole and oral analgesic diclofenac. And among the topical medications, antibiotic moxifloxacin 0.5% was started. Prednisolone phosphate was started, along with hometropin, antiglaucoma timolol, and a lubricant carboxymethyl cellulose. The patient was taken for emergency surgery. Right eye tectonic penetrating keratoplasty was done under local anesthesia. Preoperative mannitol IV infusion was given, and host trephine size was 8 mm and donor trephine was 9 mm. And the host tissue specimen was sent for routine bacterial culture, fungal culture, and also for HSV DNA PCR test. On post-operative day 1, the uncorrected visual acuity was hand movements with PR accurate. IOP was normal, graft was well opposed with all sutures buried and intact, and anterior chamber was well formed with air bubble present. Post-operative treatment was continued. The oral acyclovir was tapered after 2 weeks to twice a day, and rest of the medications were continued: moxifloxacin, prednisolone, timolol, and carboxymethylcellulose. At post-operative 2 weeks, he had a visual acuity of 3/60. Graft was still well attached. AC was well formed, and the TF film and host tissue HSV DNA PCR tests were positive. Coming to a little bit about some more cases of necrotizing viral keratitis. There can be varied clinical presentations. Here also you can see a case of necrotizing viral keratitis. So here is a stromal melting with a perforation present with uveal tissue plugging the defect. Again, this is also a case of necrotizing viral keratitis showing a corneal melt with uveal tissue plugging with a corneal perforation. And there can be varied management options in such cases. If the defect is smaller, say 2 to 3 mm size, we can do a cyanoacrylate glue plus bandage contact lens in such cases. And if the defect is larger, for say up to 5 to 6 mm, then a good option is Tenon's patch graft in such cases, which can be seen in this case. Here we did a Tenon's patch graft, seen here. Also, another new option is smile lenticule assisted patch graft. This can also be done where there is an availability of smile lenticules. We need thicker lenticles, at least 60-70 microns. We can use multiple lenticles also assisted with fibrin glue. So here, this is a case where smile lenticule assisted patch graft was done. Another case of smile lenticule assisted patch graft. Okay, I would also like to share one unusual case. This was a very interesting case. A 48-year-old male presented to RPC emergency with complaints of pain, redness, diminution of vision, and watering for 2 weeks. He had received his first dose of Covishield vaccine 5 weeks prior to the 5 weeks prior to coming to the RPC emergency. He had developed fever after taking the vaccine, which was there for 2 weeks. Then the fever subsided. Then there was a period of 1 week where there was no symptoms. And about 3 weeks after taking the first dose of the vaccine, he developed ocular symptoms, including pain, redness, watering, and diminution of vision. On presentation, our first diagnosis was a bilateral necrotizing stromal viral keratitis. Slit lamp examination showed bilateral keratolysis with central corneal perforation with a large epithelial defect in both the eyes. The vision was PL positive with PR inaccurates, and ultrasound showed massive choroidal detachment in both the eyes. We did a thorough investigation because we were not sure of the cause of the disease, because there was no characteristic history relating to the viral keratitis. There was no characteristic history to indicate that it was a bacterial or fungal keratitis. So we did a thorough investigation. We did the general condition, blood pressure, pulse rate, respiratory rate were within normal limits. Corneal scrapings were taken. Grams, KOH, and bacterial and fungal culture were negative. Nasopharyngeal COVID test, SARS-CoV-2 was negative. MON2 showed a 10 mm in duration. CBC, LFT, KFT electrolytes were normal. Only the ESR was raised. And also the other investigations relating to the autoimmune diseases and infective disease, VDRL, HIV, HLA-B27, CNK, PNK, double-stranded DNA, all the tests were negative. Serum AS, rheumatoid factor, IL-6, everything was negative. So we took the patient for surgical management. Bilateral tectonic penetrating keratoplasty was done, and this host tissue was sent for bacterial fungal culture, acanthamoeba culture, as well as PCR test for HSV, cytomegalovirus, adenovirus, and also COVID test was done on the host tissue to rule out the cause. And histopathological examination showed corneal stromal infiltration with inflammatory cells only. After 2 weeks, all the culture tests were negative. All the culture tests as well as the PCR tests were negative. So we hypothesized that it could be a bilateral immune-mediated keratolysis related to the immunization with SARS-CoV-2 recombinant viral vector vaccine, that is Covishield vaccine. This case got published in Cornea Journal last year. Thank you so much.
You, Tanvir, that was an excellent presentation. I would request Dr. Nupur to discuss necrotizing viral keratitis.
Thank you, Planveer. It was a good presentation. So what would be the take-home points from your side for people who are dealing with a necrotizing viral keratitis?
Ma'am, necrotizing viral keratitis usually present with a severe corneal melting, and usually corneal perforation is there, but our first management should be a full dose of oral acyclovir, which is the most important role in medical management. And apart from that, if a frank perforation has already occurred or an impending perforation is there, then depending upon the size of the perforation and the presentation, we can decide the surgical management accordingly, whether to do a glue BCL or a patch graft or a full thickness tectonic penetrating keratoplasty.
So I think nowadays for necrotizing viral keratitis, they are advocating a double dose, 800 milligrams 5 times a day for herpes simplex keratitis, especially in cases of necrotizing viral keratitis.
Thank you.
Would you want to add something to whatever has already been said? Sir?
Apart from the herpetic thing, you can have other, viral involvement where you can have a similar picture upon necrotizing. Herpes zoster is a classical cases where you have very difficult to manage such cases. Melting is very, very fast. And sometimes just start with a anti-chamber reaction, and slowly you can see the stromal involvement in these cases. So those are important. You can see cases which normally miss out. We think of infectious keratitis in bacterial, fungal, other things, and the viral detection, viral diagnosis is the last in most cases. And we know that there are large number of viral cases in India also. And most of the time we miss, and they come with a secondary infection, and that is the time things become very difficult to manage for our cases. So we have to make sure people identify these cases early enough, and if treat them in the appropriate time, they'll never have a secondary infection happening in these cases. So that should be the idea in these cases.
Thank you, sir.
One more thing I think which needs to be highlighted is that if a patient has had necrotizing viral keratitis, what are you going to do so that the patient doesn't have, a recrudescence later or recurrence, later?
Oral acyclovir prophylaxis can be given for 1 year.
For how long?
For almost 1 year. For 1 year.
Okay. So
400 CBD. Yeah.
So for almost 1 year, and zoster keratitis, like sir said, can be extremely difficult. They are absolutely anesthetic corneas. So even if you try to do grafts in those cases, they are very difficult to manage post-operatively. So for zoster keratitis, if you're doing a therapeutic keratoplasty, always better to, do a partial tarsography also. Because the patient will not come to know anything. The cornea is so anesthetic and you can have a epithelial defect.
Thank you, sir. Thank you, ma'am.
Now, Dr. Shanaz will present on case of acanthamoeba keratitis.
I think we'll.
What happened?
So they haven't entered.
Okay, doesn't matter. We'll move to the next one, Shanaz. Meanwhile, you can load. It's there. Okay, meanwhile, we can load this. We move on to the next presentation. Tushar, can you invite the next speaker?
Dr. Afrin will present a case of perforated corneal ulcer, and to be discussed by Dr. Sridevi.
Good afternoon, everyone. Today I'll present a case of perforated corneal ulcer.
A 20-year-old female presented with diminution of vision, pain, redness, and photophobia since 3 weeks. The problem was acute in onset and progressive in nature. She had history of vegetative matter trauma while doing household chores. Her general examination was within normal limits. On examination, right eye was within normal limits. The vision in the left eye was perception of light with PR accurate. IOP was digitally low. There was mild lid edema and there was conjunctival congestion. On examination, right eye was within normal limit. Left eye, there was a central corneal perforation, which was with pseudomembrane, which was 4 into 3.5 mm, with surrounding corneal thinning around 2 mm. There was an epithelial defect, which was 6.5 into 3.5 mm, and there was a pseudomembrane, which was pressure Seidels positive. There was area of surrounding corneal infiltrates, which was around 7 into 7.5 mm. On slit lamp examination, the anterior chamber was flat with a pseudomembrane. Ultrasound was anechoic. A diagnosis of left eye perforated corneal ulcer was made. Provisionally, patient was started on topical antibiotics and planned for left eye therapeutic penetrating keratoplasty under mannitol cover and periorbital anesthesia. Host and donor rim were planned to be sent for microbiological culture and histopath. Proper consent was taken for nil visual prognosis, and just the patient was told that infective foci would be removed and keratoplasty would be done. Initially, the margins were marked, assuming it to be fungal. 1 mm margin on either side was marked and 8.5 mark was made around, and a sharp trephine was done. Local peritomy was done. Using Vanna's scissor, the dissection was done, placing the scissors vertically so that there is minimal ledge. All the possible membranes were removed. Surgical PI was done. Multiple PIs were made. Anterior chamber angles were formed with viscoelastic. A donor corneal button of 1 mm oversize was placed and 4 cardinal sutures were placed. After the 8 interrupted sutures, the viscoelastic was washed and air was injected in the anterior chamber. 16 sutures were passed subsequently and all knots were buried and peritomy was closed. On post-operative treatment, patient was started on oral and topical antifungals and prophylactic antibacterial moxifloxacin. On post-op day 1, the vision was finger counting close to face, PR was accurate, IOP was digitally normal, the graph was clarity was 3+. All sutures were intact and buried. There was no epithelial defect. AC was deep with superior air bubble, and there were few descent membrane folds. On the microbiological examination, the donor and host bacterial and fungal cultures were negative, whereas in histopath, we could see get hyphae. On post-op day 7, the vision was 3/60, PR was accurate, graph clarity was 3+, sutures were intact and buried. There was no epithelial defect. Thank you. The management part would be discussed by Dr. Sridevi, ma'am.
So this was a case of perforated corneal ulcer. So the etiology for a perforated corneal ulcer can be infectious or non-infectious. Here we'll be focusing on the infectious cases, which are usually due to bacterial, fungal, viral or parasitic infections. The main aim behind treating these patients is two. First is to provide tectonic support, and second is to remove the foci of active infection. Visual outcomes in these cases are of secondary importance and can be accomplished at a later date once the eye is stabilized. So the management options for a perforated corneal ulcer range from tissue adhesive with VCL application, a corneal patch graft, also sometimes a tenon patch graft in certain cases, and or a full thickness penetrating keratoplasty. Some of the other methods that have been described include a multi-layered AMG or an autologous fibrin membrane, but these are usually limited to the perforations associated with ocular surface disorders rather than infective ulcers. So the management plan will depend on the size, location of the ulcer as well as the surrounding stromal involvement. So if you look at this flowchart, in cases of peripheral ulcers that are less than 3 mm in size, you can go ahead with a glue BCL and or even a Tenon's patch graft if they are non-separative in nature with resolving infiltrates. In ulcers which are 3 to 5 mm, a corneal patch graft would be a better option. Again, Tenon's patch graft is an option here, but the tectonic support will be a little less. And in case of central ulcers, if it is less than 3 mm in size and without surrounding stromal melt, you can go ahead with a glue BCL or a Tenon's patch graft if it's not suppurative. And with significant stromal melt, however, even if it's less than 3 mm, you will have to perform a full thickness graft and not just a glue BCL or patch. And in case of central ulcers that are greater than 3 mm, obviously you have to go ahead with a full thickness keratoplasty. So the tissue adhesive technique was very beautifully described by Professor. So it is basically the cyanoacrylate glue is used. It has both bacteriostatic and anti-stromolytic effect. So that is what will be kicking into action in these cases. And the success rate in infective ulcers ranges from 28 to 91%. It is more successful in cases of monomicrobial infections, in gram-positive infections. However, the duration for glue retention is lower in cases of perforated corneal ulcer due to infectious etiology. On the other hand, the odds of failure is higher in cases with immune-mediated sterile melts. So when you perform a glue BCL of in infected ulcers which are perforated, you should keep these patients on close follow-up because the glue might fall off early. So just look for any signs of reperforation on need for tectonic intervention. And the success rate is best in gram-positive etiology, followed by fungal, gram-negative, and least for the viral perforations. So in this case, we can see there is a small peripheral perforation and glue BCL is a good option in these cases without any stromal thinning. That is, on the other hand, if there is a small central perforation with resolving infiltrates and no significant stromal thinning, again, you can go ahead with a glue BCL. This is a case of small central perforation with surrounding stromal infiltrates. So in such case, Tenon patch graft is not an option. Glue BCL is a better option. And if not, then keratoplasty. Now, in some cases where you have a 3 to 4 mm, a slightly larger perforation, and if the iris is adherent onto the perforation and they're difficult to release, then you can even go ahead with the drape patch assisted cyanoacrylate glue application, where you apply a patch of drape first, followed by the glue application on top of it, so that it acts as a barrier and the glue doesn't directly come in contact with the iris tissue. A corneal patch graft is performed for peripheral perforation 3 to 5 mm in size, which do not involve the visual axis. And if due to any reason you need to pass a suture through the center or cut through the center, you might as well perform a full thickness graft in these patients rather than performing a patch graft. So in this case scenario, you can see the perforation is quite small. It's around 3 mm, but if you see there is extensive surrounding stromal thinning due to the infection is due to a viral keratitis. So in such cases, a glue BCL or a Tenon's patch graft will not work, and you will have to still do a full thickness penetrating graft. So likewise, in this case, see that there is a may appear small, there is a complete stromal thinning and melt, possibly due to a pseudomonas infection. Again, in such a case, you might need to go with a full thickness keratoplasty. So the post-operative treatment, you should continue anti-infectious therapy until the corneal epithelium is completely healed. The use of steroids is a little tricky in these cases. So if it was a case of viral keratitis preoperatively, you can use steroids with antiviral prophylactic cover. In cases of fungal keratitis, you do not use them in the immediate post-op period. So it is a good idea to wait for a negative fungal report before you start the topical steroids. So to summarize, perforated corneal ulcer, they constitute an emergency and immediate intervention is required to maintain the integrity of the globe and remove any infection. Tissue adhesive with glue may be performed in smaller perforations, while patch graft or full thickness keratoplasty, penetrating keratoplasty may be needed in larger perforations. Proper patient counseling is very important to explain to them that this is not a visually rehabilitative procedure. And post-operatively, it's important to prevent any reinfection and manage the IOP. Thank you.
So thank you, Sridevi. I think that was an excellent, comprehensive presentation. Very nicely done with good pictures. I think under the guidance of Professor Tritial sir, there was a thesis where the corneas were, cross-link corneas were used. So would you like to comment on that?
In that case, in patients undergoing therapeutic penetrating keratoplasty for fungal keratitis, the cornea, the donor tissue was cross-linked before it was transplanted, and it was found that the rate of reinfection in these cases was lower as compared to using a routine donor tissue.
Okay. Anidhi?
I think the next presentation will be on acanthamoeba keratitis by Dr. Shahnaz and to be discussed by Professor Rajesh Sinha.
Good afternoon, everyone. So I'll be discussing a case of Acanthamoeba keratitis. Here, there's a male, a 35-year-old male who presented with complaints of redness, watering, and excruciating pain for about 14 to 15 days, and he had a history of overnight contact lens use, 19 to 20 days back, and following which he continued using the contact lens, and he consulted locally where he was started on topical antibiotic as well as antifungal cover, but the signs and symptoms worsened. So the vision, right eye was within normal limit, and in left eye vision was finger counting close to face with mild superior lid edema along with the crusting of the eyelashes, and on cornea there was a ring infiltrate of 6.7 into 6.5 mm with epithelial defect of 6.8 into 7 mm, along with the area of stromal thinning and stromal haze was present. On fundus, it was within normal limit on ultrasound. So the differential diagnosis on the basis of the ring infiltrate could include acanthamoeba keratitis, gram-negative bacilli like Pseudomonas or Moraxella, herpes simplex, fungi, varicella zoster, or immune-related conditions like rheumatoid arthritis. Corneal ring infiltrates are more consistently associated with acanthamoeba keratitis, especially in the contact lens wearers. And also because here the duration of the presentation is the longer, it's around 14 days. Had it been the Pseudomonas, it could have been fulminant at this stage. So the provisional diagnosis of our case is the acanthamoeba keratitis based on the history of the contact lens use, symptom of the extreme pain, which can be due to the keratoneuritis, stromal ring infiltrate, and poor response to antibacterial and the antifungal cover. When to suspect acanthamoeba keratitis? So the history is very important here. We have to know the history of any exposure to the contaminated water and the soil, and it is more commonly seen in the rural areas or the developing countries. In the developed countries, the contact lens use history becomes more important, corneal trauma and the severe pain. In examination, we can find pseudodendrites. Pseudodendrites are the different from the dendrites seen in the herpes simplex, where we can see the knob-like structure at the end, whereas in pseudodendrites, it is more tapering at the end. Radial keratoneuritis can be seen, ring-shaped infiltrates can be seen, and the stromal thinning and furrowing can also be present. So the investigation we should do like corneal scraping, confocal microscopy, and ultrasound to rule out any endophthalmitis. In staining, scraping, we can do the staining and the culture sensitivity. So here in this case, we have done the scraping and and confocal microscopy, we found the double cyst wall. And in the culture report on non-nutrient agar with E. coli, there were tracks of trophozoites were seen. So the diagnosis here is confirmed with the acanthamoeba keratitis. Acanthamoeba keratitis is a ubiquitous free-living protozoa and can be found in two forms, trophozoites and cyst. So now coming to the management of the acanthamoeba keratitis, it can be done under the general measure, medical management and surgical management. And general management, patient counseling is very important. So as here in acanthamoeba keratitis, long-term treatment is required. In medical management, we can give topical antiprotozoal or any anti-amoebic drugs. And supportive drugs, we can give cycloplegics, anti-glaucoma, lubricants, and steroids in later stages. And systemic is given when there is scleritis, deeper lesion involvement, and the limbitis. Surgical management can be done PTK, PAC CXL, lamellar keratoplasty, or penetrating keratoplasty. In anti-amoebic topical medication, we have 4 classes of drug, and in that, the bigonide class of drug is only active against both anti-trophozoite as well as against the cyst. Whereas all other classes were only can act against the trophozoite class. Topical miltefosine has been shown to be effective, and it was shown on the hamster group, and it was found to be 85% effective. So the FDA has approved it as an orphan drug class in 2016 for the treatment of acanthamoeba keratitis. Is there any role of oral miltefosine? So there is a case report which they have shown that adding the oral miltefosine has clinically improved in pain and conjunctival infection. But there is another case series which they have shown that on adding the oral miltefosine, the inflammation has worsened. So they advise to add oral steroids along with the oral miltefosine. The surgical management includes PTK, which can be done when the involvement is only 1/3 of the stroma. PAC CXL, which is photoactivated chromophone CXL, which has already been discussed. It is more active against the bacteria, 88%, and the fungi, 78%. Although meta-analysis report has shown good healing response with acanthamoeba also, but almost half of them needed retreatment in the acanthamoeba case. So lamellar keratoplasty can be done in the early stage and can be done in the advanced stage. The early stages, it has shown to improve the management in non-responding cases, whereas in the late stages or the advanced cases, it was not shown to be very effective. So the treatment done in our case was topical combination therapy was given, like bigonite class was added, diamidine class was added, and homoatropine for the inflammation, and systemic painkillers was added. So the clinical course has shown that the patient responded very well, and in 1 month the ring infiltrate reduced and the epithelial defect also reduced. So few questions to ponder upon. Why is it so common in the contact lens wearer, and why the late presentation and the need of the longer treatment duration? So in contact lens, the biofilm formation formed due to the acanthamoeba, it is actually the main cause of the infection. And this soft contact lens wearer are more at risk as compared to the rigid lenses. And the cause of the late presentation and the longer treatment duration is because the clinical challenge, often it is misdiagnosed as the viral or the bacterial, and therefore wrong treatment is given. And the culture also provides inconsistent results. And the treatment duration is mainly because of the acanthamoeba. Acanthamoeba cysts can survive several years while maintaining their pathogenicity. So the take-home message, proper history taken is very important. Importance of the corneal scraping should never be ruled out. In non-responding ulcers, one should think about the atypical infections, and patient's counseling is very important for the need of the long-term treatment, and the keratoplasty may also be needed according to the response of the patient. Thank you.
Yeah, thank you, Shanaz. Actually, this is a case, let me just tell you about the case. This is a case which presented to us with a ring infiltrate, giving a history of wearing contact lens and sleeping while wearing contact lens. So you can have a long list of conditions wherein you can have ring infiltrates, but two things you should definitely remember. If you have a ring infiltrate with a history of contact lens use, with history of sleeping with contact lens or swimming while using contact lens, then two things should come to your mind. One is Pseudomonas keratitis and the other one is acanthamoeba. Now this patient presenting with 20 days history and still not perforated, it is unlikely in Pseudomonas, which will perforate very fast. So that will shift your mind towards acanthamoeba, and a history of excruciating pain, so which is disproportionate to the symptoms. So these two things will shift your mind towards acanthamoeba. You will investigate accordingly, and while investigation, she could achieve that double wall cyst. She could get in confocal microscopy. So that was enough to make a diagnosis of acanthamoeba keratitis, and you have to treat accordingly. Fortunately, this patient healed nicely. Many times it's a refractory one as well, but it takes a lot of time to heal, and sometimes it doesn't. So you have to think about, therapeutic lamellar keratoplasty or a therapeutic full thickness keratoplasty. All these things you may have to do. But fortunately, this patient healed. Only thing, one, you should remember that even if the patient heals, such patients, they require a very long-term treatment, at least twice a day. These bigonides you can give for a very long period, maybe around 6 months or so, because the cysts, they have a tendency to remain in the stroma for very long. And these cysts can, once again, it can heal, and once again it can come back. So that is why these patients require a long-term treatment with the bigonides. And a very strong message that goes from this case is that a lot of you people as well as a lot of patients can be, using contact lens. And if you are using contact lens, one should not sleep while wearing contact lens. One should not swim while wearing contact lens.
So thank you, Shanaz, for a very nice overview of Acanthamoeba and Rajesh. I have one question, Rajesh, and I'm sure you will be. What is your experience with miltefosine, topical and systemic both? Do you think it works, and do you think it is going to be the drug of future, or
Yeah.
you think
Actually,
we have to look for
ma-
another
yeah.
drug?
Actually, ma'am, the thing is that we need to have a large number of cases to be treated by miltefosine to actually make a comment that whether it is an alternative to PHMB, a better or not as good alternative to PHMB. So till date, we don't get too many cases. So whatever case we get, we treat with mostly with PHMB. But yes, miltefosine is something which can be tried, and yeah, maybe a comparative study can give us an idea about it.
Thank you. Vanati, can we have the next?
I think the important take-home message is the duration of time the therapy should continue in cases of acanthamoeba keratitis, which Dr. Rajesh rightly emphasized. And for residents who are doing therapeutic keratoplasties, they will have to remember that anti-acanthamoeba treatment needs to be continued for 6 months after the period of healing of the graft. So that's important. And also when you take up these patients for additional procedures, like if they're going to need a cataract surgery subsequently, or if you're planning a lamellar graft for these patients subsequently, you probably will have to look at a long-term anti-acanthamoebal therapy for them. And the cyst, as Rajesh rightly pointed out, can remain dormant for a very, very long period of time, going to about even 5 to 10 years and become activated subsequently. So that's a message which all residents who are managing these cases will have to remember. I think we'll now invite Dr. Nishat Hussain Ahmed, who is our ocular microbiologist and offers us excellent support in all our ocular infection management. Over to you, Dr. Nishat, to talk to us on the evolving patterns of antibiotic susceptibility in microbial keratitis, our experience.
Thank you, ma'am. A very good afternoon to one and all present here. I'll be sharing our experience in the evolving patterns of antibiotic susceptibility in microbial keratitis. So when we investigate a case of microbial keratitis, largely we want to look for the presence of one or more of bacteria, fungi, viral or parasites. Now, quite often, especially in case of bacterial and fungal keratitis, it is not possible, especially in a tertiary eye care center, to pinpoint whether we want to look for a bacterial pathogen or a fungal pathogen. So here I want to emphasize that most of the cases which come to our center, they are investigated for both bacterial and fungal pathogens. There are very few in which only fungi or only bacteria are looked for. Then we are also doing tests for viral pathogens as well as parasites. When we speak about total microbiologically confirmed microbial keratitis in the center, then a large chunk, that is 56.4%, is composed of bacterial pathogens, 42% are fungal pathogens, 1.4% are viruses, and acanthamoeba are 0.1%. We see a lot of mixed infections also. This is the data of 2018 and 2019, where we saw 36.2% mixed infections in microbiologically confirmed microbial keratitis cases. 34% of them were 2 infections, and 2.2% of the cases, they are having 3 infections. So we now move on to bacterial keratitis. What are the important pathogens and how much they are susceptible to the currently prescribed antimicrobials? So I'm presenting the data of 6 years, 2015 to 2020. And as we are able to see here, that the total cases investigated from 2015 to 2019, they ranged from 1,500 to more than 2,000 each year. And the positivity, it ranged from 20.1% to 30.1%. So the differences over these years were not statistically significant except for the year 2020, where very few cases were investigated because of the nationwide lockdown. We are also able to see that the most common pathogen isolated is coagulase negative staphylococci, followed by Pseudomonas aeruginosa and Staphylococcus aureus. And then there are other pathogens, other bacterial pathogens also. And the variations in the numbers, again, they are not statistically significant over the years. So if we talk about in totality, the data of 6 years, we can say that coagulase negative staphylococci was the most common pathogen, forming 61% of the isolates, followed by staphylococci and Pseudomonas, Staphylococcus aureus and Pseudomonas aeruginosa. And these red colored, these are the members of enterobacterials. These are gram negatives, which are also important pathogens in bacterial keratitis. Here it will be clearer. So the dark blue is the a contribution of coagulase negative staphylococci. Then 14% we are having Staphylococcus aureus and Pseudomonas aeruginosa. And then small parts are from enterobacterials, very few Streptococcus species, and non-fermenting gram-negative bacilli. The speciation of coagulase negative staphylococci we are not routinely doing. However, in some anecdotal studies, we have done the speciation to find that 56% of all coagulase negative staphylococci are the Staphylococcus epidermidis, followed by Staphylococcus hemolyticus, and then there are others as well. Now we will see the resistance pattern of Staphylococcus species. So the good news over these 6 years has been that all the isolates of Staphylococci in all the years have been uniformly susceptible to vancomycin. However, also the methicillin resistance, which is depicted by cefoxitin resistance here. Cefoxitin resistance, it is a surrogate marker of methicillin resistance. So this was also very less, from 25 to 35%, except for 1 year where it was more than 40%. So this is not a very high methicillin resistance in a tertiary eye care center. However, to commonly prescribed fluoroquinolones, this is ciprofloxacin, moxifloxacin, gatifloxacin, the resistance seen was very high. So in all the years, almost all the years, 40 to 60% of the isolates, and sometimes more, they were resistant to fluoroquinolones. Also, the resistance was very high to erythromycin and clindamycin, more than 50% to up to 70 to 80%. Isolates were resistant. However, we were able to see that less than 30% of the isolates in all the years were resistant to tetracycline and chloramphenicol, and also very less resistance was seen, less than 20% against the aminoglycosides, and we were even able to see a decreasing trend over the years against gentamicin and tobramycin. Next, we move on to Pseudomonas aeruginosa, and here again we are able to see that against commonly prescribed cephalosporins, this is ceftazidime and cefepime, two important anti-pseudomonal cephalosporins, and also aminoglycosides and fluoroquinolones. The resistance seen was very high. So 40 to 60% of the isolates were resistant in most of the years to these commonly prescribed antimicrobials. Good susceptibility was seen against piperacillin, piperacillin tazobactam, and imipenem. Also, very less resistance was seen against polymyxin B. Less than 20% of the isolates in most of the years were resistant against polymyxin B, and we also could see a downward trend, a decreasing resistance over the years against polymyxin B in Pseudomonas aeruginosa. But the sad part in case of Pseudomonas aeruginosa was that there was no anti-pseudomonal drug against which all the isolates were uniformly susceptible. Similar was the case with enterobacterials. These, as I said, are gram-negative bacteria, which are also important pathogens in bacterial keratitis. So there was no drug against enterobacterials against which all the isolates over the years were susceptible. Also, we were able to see that against penicillins, cephalosporins, and fluoroquinolones, the resistance was very high, 50 and above. more than 50 isolates were resistant to these antimicrobials, which are commonly prescribed. Less than 40% resistance was seen against gentamicin, amikacin, tetracycline, and chloramphenicol. And even better results were there against piperacillin tazobactam and carbapenems. We will see a little bit about fungal keratitis now. I'm presenting the data of 19 years from 2001 to 2019. And out of 23,500 cases included in this study, the overall culture positivity was 22%, and 1.2 to 3.7% were mixed infections, mixed fungal infections, that is, yeast, mold, etc. So this looks like a busy pie chart, but if we dissect it, we will be able to understand that these three, belonging to the genus Aspergillus, they are the major pathogens, causing 30.4% of the fungal keratitis cases in our setup, followed by Fusarium, which causes 21.4% of the infections. Also, Dematiaceous fungi as a group, which includes Alternaria, Curvularia, Cladosporium, etc. They also were pathogens in 32.6% of the fungal keratitis cases, and yeast accounted for 6.6% of cases. If we see the trend over the 19 years, we can see that this purple colored, this is Dematiaceous fungi, and this one is Aspergillus species. So they are maintaining their top positions as fungal pathogens. There are some dips and rises over the years, but they are not statistically significant. Also, this green colored, this is Penicillium, and this light blue, this is Mucormycosis. So they are respectively causing 5% or less or 0.5% or less of fungal keratitis cases, and over the years a trend has been maintained of very low positivity. However, if we see this red graph, which is of Fusarium, we can see that some constant positivity was maintained up till 2015, but after that there is a dip. So now we are able to see very few Fusarium isolates in our fungal keratitis, which suggests that there may be a changing pattern in the pathogens. Also, very worrisome that these two, this orange, which is the Candida, and this black, which is Rhodotorula, these both are opportunistic yeast fungi, and they are showing an increasing trend over the past 5-6 years. Antifungal susceptibility testing, we usually do not do on routine basis. However, in some of the studies, we have done it. And I'm presenting the data of 50 pathogenic fungal isolates. And some of these are also included in one of the theses, which was guided by Professor Vananthi. So these were the isolates which were included in the study. And we were surprised to see that all the isolates, be of any genus, they were uniformly resistant to fluconazole, caspofungin, and micafungin, totally resistant, more than 32 microgram per ml minimum inhibitory concentrations. Also, we were able to see that our Aspergillus isolates, which were included in the study, they had lower MICs against the azole group of antifungals, voriconazole, itraconazole, and posaconazoles. Most of the isolates had very low. We are showing a range, but the isolates, most of them are at the lowest end of the range. However, the Fusarium species, they showed more lower MICs against the natamycin. So this was the trend in the few fungal AFST which we did. And I humbly acknowledge the collective effort of all the cornea units and ocular microbiology section for the management of microbial keratitis patients. Thank you for your patient hearing.
Thank you, Nishat. I think that was tremendous presentation, excellent presentation, so many years, and we've become so much wiser, but just by looking at your presentation, and you presented so well, everything became, everything now is fitting into our clinical jigsaw puzzle. Whether it is the fact that, why is it that our fungal keratitis is responding more to azoles as compared to the data which is being published in the south. And I think that says it all, because we have a lot more Aspergillus, and we have Candida also, which is now responding to azoles. So that is why I always say, and I still maintain, trials like MUT1 and MUT2 should be, done here after, of course, modifying them, I'm sure the results are going to be different. So that was really very good. So
Thank you, Nishat. Wonderful presentation. Let's go to the next session, Namrata.
So we come to next very important session, which
invite Nupur and Mantri to be on a dais.
Yeah.
Along with Rajesh Sinha here.
Rajesh. Sorry.
This is Rajat.
Manpreet, you can come in front. Or Manpreet, you can come here.
Yeah, better, better. ऊपर बैठ जा please.
Okay, I think it is going to be another very important session because this is something which we all encounter and something which we should all know about. And that is corneal emergencies and surgical care. I would request Dr. Nupur to call the next speaker.
So a very important talk on traumatic corneal laceration repair. Professor Tushar Agarwal, please.
Thank you. So we move on to the final session, and I'll be talking about repair of traumatic corneal perforations. Now, these account for almost 6 to 14% of all cases of ocular traumatic injuries, and usually you get younger patients who get injured with various household items. Now, clinically speaking, corneal perforations can be of three types, depending on the extent and the thickness. So, you can see partial thickness wounds, then you can have self-sealing wounds, and then you can have full thickness incisions. So management-wise, if you have a full thickness perforation, the management is straightforward. You have to suture the incisions, the wounds. However, in the previous two scenarios, you do have some other choices. If you have a flap which is not displaced, you can just apply a bandage contact lens or glue. Suturing is usually not required. If you have a displaced flap, then suturing is required to keep it in position. Otherwise, the inherent elasticity of the cornea is not going to allow the flap to remain in position. Self-sealing lacerations are rarely seen sometimes. And if it's a very small pinpoint type of laceration, one can just observe and prescribe topical antibiotics. However, slightly larger self-sealing lacerations require adjuvants like BCL or glue. The cornerstone of management, however, is that one has to err on the side of more rather than less while managing a perforation. So if you have any doubt, suturing is the best option. Regarding the management, first things first, one has to assess do not forget the patient while taking care of the eye. You want a healthy kicking patient to do practice ophthalmology. So any life-threatening things should be taken care of first, including basic management like the airway management, the ABCs of the first aid care. And in the casualty, of course, tetanus injection is also given to the patient. Regarding the workup, the critical sign is RAPD, which is shown to be a very good and a strong prognostic indicator regarding the visual recovery. So that should be documented. Other than that, as far as possible, you will mostly encounter difficulties in proper examination in the OPD or in the casualty area, as the patients are not very cooperative. However, you should try to document as far as possible, because a lot of these cases will end up being medico-legal cases. So compared to a routine OPD case, these cases require a much more thorough documentation of both the history and the findings. As far as possible, do not commit regarding the history just on the word of the patient. It's always good to add the word alleged before any history is written in the file. And if you have access to a photographic system, then it is best to photograph as far as possible all the lesions which are present. The goals of the management are to ensure a watertight globe, not an airtight, but a watertight globe, and to have a normal intraocular pressure. one should remove as far as possible all contaminated and non-viable tissue and any foreign bodies which if they are superficial in nature. We are not talking about the retained intraocular foreign bodies, and avoid iatrogenic damage at all costs. Most of these cases require general anesthesia for surgery. So again, if there is any doubt, err on the side of more and go for general anesthesia. However, very small perforations, especially in adult patients, which are especially like self-seal perforations, one may get away with topical anesthesia as well. Now coming to the surgery part, compared to any other corneal or lens surgery, all surgeries are different when you are repairing perforation. However, I shall try to share some surgical tips which are universal in nature. The first thing is to thoroughly wash the entire surgical field with the normal saline, and then the any debris which are hanging out of the eye can be excised. One needs to create a surgical access to the anterior chamber. So create two side ports. The location should be as if you would be wanting to use a vitrectomy probe or a bimanual IA probe for this setting. So make your side ports accordingly. So in this particular case, this was I think an 8 or 9-year-old girl who had a perforation. She was brought from Bihar, and they waited for almost 48 hours. They were going to various centers there, and finally they came here. And so she had a traumatic cataract. I had after a consultation with the parents, I had planned that if possible we'll implant the IOL in the primary setting, or if not possible, then we would undertake a secondary sitting. So the goal is to first seal the corneal perforation. So as you'll see that as I come towards the center, I'll keep decreasing the size of the suture length and keep making it smaller and smaller, so that the sutures should impinge on the pupillary area as least as possible. Sometimes, not in this case, but sometimes another technique which I used to employ was that instead of putting sutures directly perpendicular to the incision, you can also place slightly diagonal sutures so as to keep the suture track away from the pupillary area. That is another technique which can be used. Normally, I keep in perforation repairs, I keep wearing the sutures as I go. And so I'll just forward it, and you can see that the sutures keep becoming smaller and smaller. Then I was not particularly sure what were the contents which were coming to the perforation site. So first I removed stained the capsule with and the anterior segment constituents with the trypan blue. Then I used bimanual IA to remove the flocculent lens matter. And once I understood the anatomy of the injury, there was a large posterior capsular defect in this area with vitreous prolapse in this area. Then I used irrigation aspiration probe to remove the lens matter, followed by a vitrectomy probe to remove the vitreous. And at this stage, I decided not to put an intraocular lens in the primary setting because the support was not enough at this stage. You can always undertake lens surgery later on. And the side ports also I closed with the sutures, and this was the end of the case. This girl actually underwent a secondary IOL by Professor Rajesh Sinha 2 months, 3 months later, and she regained 6/6 vision. I clearly remember this. And the reason I remember was that the father was a cardiologist. So you remember these cases. This is another case where I'd like to show that one need not be disheartened. So this is, if you see a very large perforation, so this is a large corneoscleral perforation. Most of these cases come secondary to road traffic accidents or firecracker injuries. So the first goal is to delineate the extent of the perforation, because in the first go you will not be able to see the extent of the perforation. So you have to create a peritomy all around, and then identify the last point where you can see the normal sclera, and then you first put a suture at the limbus, because those are the two sort of the identifying anatomical marks which can allow you to align the corneal tissue. So you can put either a vicryl on the limbus or a 10-0 to first sort of align the cornea, and then you use vicryl on both sides, and then you use vicryl to close the 6-0 or 8-0 vicryl to close the scleral defect, and then you keep coming towards the center and close the corneal defect. And finally, you wash the anterior chamber with BSS, and it's always prudent to add, especially in such large injuries, topical antibiotics in the anterior chamber. So a lot of these patients come with associated lens injuries. So if you have obviously a disrupted capsule and flocculent lens matter, as we saw in the first case, or if there is vitreous involved, you have to remove the lens in those cases. The putting the lens is the surgeon's choice. So if you find good support, so do not again on this side err on side of less than more. So if you are 100% sure that you have good support, you can undertake an intraocular lens implantation. Usually the biometry from the other eye can be taken effectively. This is a case where combined surgery was done. So this was a small perforation. And in such cases, in smaller perforations, even keratometry from the eye with the perforation is quite accurate and can be taken. Of course, the astigmatism will not be very accurately measured, but the overall lens power can be measured quite accurately. So you can just close the perforation and then do the cataract surgery. Most of these cases, you will find some defects in the anterior lens capsule. So the choice of the lens is usually a 3-piece lens rather than a single-piece lens in these cases. And one last thing is that in pediatric traumatic cataracts, always do a PCC or in a larger age group. So for example, in a developmental cataract, my cutoff is around 4 to 5 years of doing PCCs. In such cases, it will be around 8 to 10 years. And that's the end of the case. The post-operative management centers around the control of infection to suppress the inflammation and to stabilize the ocular surface. So compared to your routine cataract surgery, the post-op medication is similar, but in a more intense manner. And there is a addition of systemic antibiotics in all such cases. You can see all sorts of complications in these cases, and one has to manage them accordingly. The take-home message would be that do err on doing more for the perforation than less. For example, if you are doubtful that whether it can be managed medically, err on the side of doing the suturing. Do not cut anything which you have not made sure after what the tissue is, because sometimes you might take out vital tissue, and do a thorough surgery at the first go, because that's the most important aspect of management of these cases. Do not be in a hurry in these cases. Thank you.
Thank you, Tushar. Wonderful tips for handling such a difficult cases. And given a scenario in our various places, even in our institute, these difficult cases are managed by young, energetic people, and they have to really understand the basics of managing trauma. Because it's not only the eye, as Tushar rightly pointed out, they can have many other areas which may be damaged. You might see a just perforation in the cornea, but if you take the patient inside under general anesthesia, you might see the entire extent of injury, which may not be possible to reach the posterior extent. So severity cannot be judged on a first examination in these patients. Therefore, the consent has to be taken in a different manner and at different times also with these pediatric patients coming with the injuries. I remember one case, a BIP patient came with a lid injury, a cracker-induced lid injury only, and there was a transverse tear in the lid. And we have called the best lid surgeon at that time in the center to repair the lid. Once the patient was anesthesia, we found the entire globe was divided into halves. And the parents were surprised. They said, this is just a lid injury, and we thought, and they were called inside and shown the entire eye. And ultimately, that was a thysical eye subsequently, and we had to do many other procedures. So don't take it lightly. These are very difficult cases. Even you repair on the table nicely, you never know how this eye is going to react subsequently in the life. And these are always a weaker eye for a lifelong. And whatever comments and the tips Tushar gave were appropriately, correct ones, and we have to follow that. Suturing the cornea is an art, not only keratoplasty. Perforation is a real art. Sometimes there can be a tissue loss also, which cannot be appreciated because so much edema will be there in these cases. Now, you may require a tissue sometimes also. And don't just take lightly because these patients might gain a good vision, like 6 vision after surgery, 2 surgeries. And we have had a cases. I remember one case with Dr. Namrata Sharma, post epikeratoplasty infection. We are inaccurate to begin with so much infection, and she regained vision after therapeutic keratoplasty. So never get disheartened in seeing the amount of injury in these patients, and they are young patient and it's a normal tissue, and sometimes recovery can be really remarkable, and other way around also. So both side has to be looked into. As for a combined surgery, you can always look on the table how you're going to react. The secondary lens implantation, secondary intervention of a lens is always comfortable for a case if possible. Otherwise, thank you, Tushar, for showing that. I think that this was one of the most important surgical videos to be shown. Rajesh, any comments? Because you were the person giving 6 vision.
No, no. Actually, it was very well corneal suturing done by Tushar. Uh, no, actually, these kids have a very long life, and so that's why I think a proper planning and a good suturing to be done should be done by by the senior residents, and that is something which I would like to emphasize.
What about the posterior segment assessment for these patients?
Yeah, and of course, all these patients have to be evaluated after that because just doing the suturing is not going to help. After that, for rehabilitation, for visual rehabilitation, you have to examine not only the lens, like if there is a lens trauma, then you have to also see the posterior segment, whether there is a foreign body behind, whether there is any detachment or anything behind. So all these things have to be very carefully evaluated so as to provide good visual outcome. Because once again, I would emphasize these kids have a very long life to live. So we have to be very careful and a personal touch should be given.
I would now like to invite Dr. Nuit Lomi uh, for the for his talk on management of acute chemical injury, a very important corneal emergency. Dr. Lomi, please.
Thank you, ma'am. Very good afternoon to you all. I was speaking on management of acute chemical injury. It's another very important topic here, where every ophthalmologist will have to face one or the other way, like to handle the case of acute chemical injury. The ocular chemical burns are a real serious ocular emergencies, and you have to be very prompt and active in the management. And immediate management is important. It can be from a very mild irritation, from a very severe permanent loss of vision can be there. So the chemicals can be alkalis, which is very more common, like ammonium, the household chemicals, the fertilizers and all. The acid are the like sulfurous acid from the batteries and all, and irritants like any from chili powder or any from shampoo powder, or so like these alkalis are more devastating. They cause more rapid penetrations. So a bit about the pathophysiology of chemical injuries, like it is necrosis of conjunctiva and corneal epithelium, cause disruption and occlusion of the limbal vasculatures, which will cause loss of the limbal stem cells and then cause further conjunctivalization and vascularization of the corneal surface. And further, it will cause a persistent corneal epithelial defect with sterile corneal ulcers. So looking to the classification of chemical injury, it's important to assess the severity and prognosis of the injury, where you have to look into account the corneal appearance, the extent of the limbal ischemia, and the percentage of congenital involvement. So this classification by Roper Health is divided into 4 grades to take into account the corneal involvement, the limbal involvement, which have been prognosticated subsequently. In grade 4, there is total corneal opacity with total obscuring of the iris and pupil, where ischemia of more than one half of the limbus is there. So there's no barrier between like 50% to 100%. So this new classification by Duas, which further classified into 6th grade, taking into account the limbal involvement in clock hours and also the bulbar conjunctival involvement in percentage wise. So coming to the management of this acute chemical injury, the primary goal of treatment is restoration of an intact epithelium, the control of acute inflammatory reactions, and prevention of this progressive melting and of subsequently complications which can occur. So the management can be divided into not only depend upon the severity of the disease, but it can also be look into account the stage where the patient had presented. It may be immediate at the immediate stage, or it can be acute stage, intermediate, or management of the sequelae. So the first immediate stage, it is a first aid where you have to give a very thorough wash of the eye with saline of at least 30 minutes. So this is very important. Whenever you see patient come in a casualty, you should not wait. You should give the prioritize of those chemical injury patients. And then after that, after assessing, after washing for at least 30 minutes, you have to also see for any particles, any insulting agents if it is there on the slit lamp, and also you have to double invert the eyelid and have a look if there is any insulting agents are there. And particularly for the children, I know, like the child has to be undergo general anesthesia, so the NPO have to be told beforehand to the parents also. And then every after 15-20 minutes time while you are washing, you have to check the pH. pH have to neutralize again. So assessment of the injury of the history and the examination again very important here to emphasize that that chemical injury can be a medical legal case again. So every thing have to be well documented. So the standard medical treatment is the main treatment is like to reduce the inflammation there, where you use topical steroid in the form of prednisolone 1%, or you can use 0.5% of dexamethasone 2 hourly, and antibiotic preferably non-epithelial toxic, non-preservative. And on you can use topical sodium citrate 10%, which inhibit the polymorphonucleus degranulation by calcium chelation, and also topical sodium ascorbate 10%, which promote the collagen synthesis. Artificial tears is again important, which promotes the reepithelializations, and the topical cycloplegic, which relieves the pains, and also you can have oral ascorbate in the form of vitamin C 500 mg 4 times a day, which promotes the collagen synthesis. And if if there's rise in intraocular pressure, then you have to start with the anti-glucose medications. Coming to the intermediate stage, review of the patient is important again, and the steroid have to be repeatedly tapered again. Like it is have double source, so like in order to prevent any side effect from the steroid, so you have to take care. If there is any sign of this stromal infiltration is there, then definitely you have to go for corneal scraping again and send for microbiological examination of gram and then KOH again. And also the prevention of simulant formation is important again here. Like for that one, you can either use a glass rod or a wet cotton wipe, which can be wiped in the furnace area. And also you can explain to the patient to frequently move the eyeball in order to prevent the simulant formations and look for any reepithelializations. There are various biological treatment options for acute chemical injuries. Coming to like amniotic membrane, you have got autologous serum, umbilical cord serum therapy, and also autologous platelet-rich plasma. So amniotic membrane has a mechanism of pro-epithelialization. It have got various substrate of for cell growth like insulin growth factor, like fibronectin, then And you have got this anti-inflammatory properties, that antivascular and also antifibrotic properties. So there's studies in from our center which have shown that for grade 4 and grade 5 of this DUAS classification chemical injury, which have shown a significant better result as compared with the standard medical therapy alone, and not so in the case of grade 6 ocular injury. Another RCT done in our center, which have shown that compared the umbilical cord serum versus autologous serum and then artificial tears, looking into account the outcome parameters like pain score, epithelial defect, size and area, the symbol formation, corneal clarity, and limbal ischemia extent. We saw that the umbilical cord serum group have better mean time to complete epithelialization, decrease in the epithelial defect diameter, and decrease in limbal ischemia were found to be better in case of umbilical cord serum group, and they have better clear corneas with cord serum as compared with the autologous and artificial tears group. Another which supported this hypothesis that it have umbilical cord serum has better, more effective in ocular surface restoration, and also is have faster healing of persistent corneal epithelial defect. Another which shows the comparison of umbilical cord serum drop along with the compared with this amniotic membrane transplantations, especially in grade 3, 4, and 5, presenting within the first week of injuries, which have shown that the umbilical cord serum group has better advantages in corneal clarity, better pain control, and avoidance of surgery in the inflamed eye, and also have significant improvement in the tear breakup time, and less corneal vascularization is seen in case of cord serum group. There's another study from our center again, which have shown the effectiveness of autologous platelet-rich plasma drop for acute chemical injury, especially from group 3 to group 5, which have shown that it can be promote repitalization of the ocular surface and it can be administered along with the standard medical therapy. So the take-home message from this presentation is the treatment have to be prompt, which is a keystone to improve the final outcomes. And it is usually recommended that all eyes with grade 3 to grade 6 DUAS classification receive at least one type of biological eye drop in adjuvant with the standard medical therapy in the acute stage and continue slow tapering until inflammation has completely resolved. Thank you all for kind attention.
Thank you, Lomi, for a very nice presentation. Any comment?
I think Lumi presented extremely well, highlighting all the points. 2 or 3 important things are that amniotic membrane transplantation helps in managing these patients in the future, because if you have to do a surface procedure like a slit or cleft for them, which were again shown so beautifully in the morning, and if a previous amniotic membrane has been done, then your dissection planes become a lot cleaner and neater, and the pannus comes out very easily. It just strips off, and that happens if you've used previous amniotic membrane. Second thing is that even if there is the slightest amount of tuna or slightest amount of chemical there, please run and take it out, because if that forms a depot and you are putting an amniotic membrane over that, then all your efforts are wasted, because that is going to act like a depot and will keep releasing the chemical. So lots of times, although they have been managed in the emergency, but the tuna particle is there, and when you try to do a surface procedure, you find that those bits and pieces are still there. So for people who are managing in the emergency, it is very, very important. You doubly avert. You wash with whatever is available. It could be clean water also. If it is not in a tertiary eye care center like this, wash thoroughly and remove every single bit of the chemical agent there.
Just one practical point for everyone who is managing chemical injury. While you are washing, you wash it thoroughly and then wait for 5 minutes to look for pH, because immediately when you look for pH, then it will not be correct, because it will give you pH of the saline that you have used to wash. So wait for at least 5 minutes and then look for the pH.
Thank you.
Thanks.
Thank you, Lomi. You can understand, this workshop had 3 segments. All 3 segments are very important. First segment is over. Second segment is lunch. That is very important. And third segment is wet lab. And we have arranged, unsuitable corneas for a keratoplasty. We have goat size. So you can use, various techniques there and apply your, skills to do a big bubble. You can do a DMEC roll preparation. You can do a lamellar dissection. You can do a full thickness keratoplasty. All those people who are interested, they can give name to our young talented senior residents around. So they'll book your seats in the high profile area managed by Dr. Tushar, because prior booking is also required in those places. But I think we had a wonderful session, and the interaction could have been much better. But the message was very clear, and that's why we made a very, as Rajesh was telling me, it was a very crisp program to cover important areas, because everything cannot be covered. But these are very important areas which are more practical. Everybody would see those cases, and people will definitely learn. You might have a similar workshops happening across the country through webinars. But every time you listen to somebody, you will gain something. It's not that we are not gaining anything. We also gain listening to so many things. One single question can make the entire workshop vibrant. So that is the importance of people sitting in the audience, because their presence makes the thing much more, you can say, lively. Not only in the audience here, it is lively for a YouTube and Facebook also. And the discussion makes the interaction much more, fruitful for our people. The faculty, the response changes. If you have an audience, the people presenting their response is different. You can say their body language also changes. So things have changed. Let's hope remains like this. COVID is still there. It's not gone. I would request all of you to take proper precautions so that we don't get into a lockdown situation. That may not happen, but we still have to take a precaution. I'll give it to Dr. Manpreet, the Sutradhar.
Thank you, sir. We would like to felicitate our Chief RP Center, Professor Jeevan Estityal. I invite Dr. Ritvi Sahu, Secretary, Ophthalmic Research Association, to felicitate, sir. Yes, sir. I request Dr. Shehnaz to felicitate Professor Namrata Sharma, Head of Cornea Services of Unit 4. I request Dr. Afreen to felicitate Professor Vanathi on behalf of Professor Radhika Tandon, Head of Cornea Services Unit 6. Ma'am, please. We have lunch for the delegates and residents on 7th floor. For wet lab, Dr. Sarath is here. Please, if you could give your name, Dr. Sarath, if you can stand up and they can see you. Please give your name so that we can organize the further session after 2:30. And I invite all the faculty and presenters and residents of our cornea services for the group photo. Faculty of Unit 3, 4, and 6 for the group photograph.